Dr. Monica knows me.
We have heard you, madam. We have heard you before.
Okay, thank you.
Good evening, ma'am.
Good evening.
Okay, Priyanka, can we start now?
Ma'am, program will be live in just few seconds.
Yeah, sure.
Monica knows me.
We are live now.
Yeah.
Good evening, all respected faculties and delegates. I welcome you all on the behalf of Public Awareness Committee Fogsi with South Zone for the episode 6 of Core Connect Live webinar. I invite all the respected faculties and delegates to join together for lighting the lamp, and let's take the name of the God. Thank you all. Coordinators for the today's event are Dr. Monica Umbardan and Dr. Shatabdi De. Dr. Monica Umbardan is consultant of OBS and Gynae.
Let it be. Don't introduce, let it be.
Okay, ma'am.
In short, I'll introduce myself and Shatabdi as conveners and coordinators for this program. I welcome all the esteemed faculty for the 6th episode of the Public Awareness Committee Zonal Webinars. This webinar is with all the South Zone societies, and the theme for our webinar today is cervical cancer prevention and vaccination. This is in accordance with the theme of our President Rishikesh Pai sir, because our focus is on non-communicable diseases this year. So, to carry this forward, we have organized this so that we can carry the message to all the faculty as well as the delegates in every nook and corner of India about vaccination, screening methods, and the conservative management of CS cervix. We hope to give a lot of take-home messages to our delegates who are online. I also take privilege in introducing Dr. Priyanka Roy as the chairperson of Public Awareness Committee. These webinars are a brainchild of his. Welcome, Dr. Priyanka. He is a chairperson of the Public Awareness Committee and a consultant in infertility and diabetes Nova IVF. Yes, sir. I request you to welcome all the faculties and introduce Aswat sir as the guest of honor for this webinar.
Thank you, Monica. Good evening, everyone. It gives me immense pleasure to welcome all of you to this yet another Public Awareness Committee program with the South Zone societies today. We are indeed privileged to have so many delegates joining us for the programs across the country. And as of now, we have had almost 2,500 plus delegates who have joined us for our programs all around. First of all, I would like to thank and welcome our President Fogsi, Dr. Rishikesh Pai sir, Secretary General, Dr. Madhuri Patel ma'am, Vice President, Dr. Alka Pandey, and our National Coordinator and the immediate past Chairperson, Dr. Kalyan Burma. For today's program, Dr. Bharti Rajshekar and Dr. Raghavendra Prasad, welcome. Chief guest today, Dr. Rishikesh Pai sir, will be joining us in some time. Our guest of honors for today's program, Dr. Ashwat Kumar sir and Dr. Anjalakshi ma'am, welcome to this program. We have expert speakers for this session, and we have Dr. Leela Digumati ma'am. Thank you, ma'am, for joining us in spite of your busy schedule. We have our esteemed chairpersons, Dr. Ramani Devi ma'am and Dr. Jeena Baburaj ma'am with us today. Thank you so much for joining. And we have two exciting panels on cervical screening and vaccination, and another one on modalities of conservative surgical management of CS cervix. To moderate the panels, we have Dr. Bharti Rajshekar ma'am and Dr. Aruna Suman ma'am, and Dr. Raghavendra Prasad and Dr. Kiranmai will moderate the second panel. Today's session are Dr. Sarina Gilbas ma'am, and the other panel, the expert is Dr. Manjula Anandani ma'am, the best experts that you can think of for a panel on this topic. Our panelists today, Dr. Geeta, Dr. Prabha Desai ma'am, Dr. Lata Chaturvedala ma'am, Dr. Chandra Ponuswamy ma'am, Dr. Rupa Prakash ma'am, Dr. Amrita ma'am, Dr. Padmaja and Dr. Archana Singh ma'am. Welcome to this session. I would also like to thank the panelists for the next session, Dr. Shishaya, Dr. Maya Mallaya, Dr. Sunita, Dr. Sandhya Rani, Dr. Ramya, Dr. Mariam, Dr. Swati, and Dr. Aparna to this session. So welcome everyone. And I would also especially like to thank and welcome the coordinators for today's session, Dr. Monica Umbardan and Dr. Shatabdi. Welcome. Now, I would now like to welcome our guest of honor for today's session, Dr. Ashwath Kumar sir. Dr. Ashwath, as we all know him, is another stalwart of Fogsi, has done so many programs for Fogsi, and especially the best part with him is he conducts so many postgraduate training program, of which I have been a part of most of his programs and totally love these programs. He is an expert laparoscopic surgeon, and he is also a professor and professor in the Department of OBGYN at the Jubilee Mission Medical College in Thrissur. He has been a past vice president of Fogsi. He has been awarded a number of awards, and currently he is also the president of the Kerala Federation. Welcome, sir. It's a pleasure to have you with us. Requesting a few words of encouragement.
Thank you, Priyangur. And it is respected Rishikesh Pai sir, Madhuri Patel madam, Alka Pandey madam, and Priyankur, and today's coordinators Monica and Shatabdi. And thank you, Priyankur, for inviting me. Any program, Priyankur is my student as well as he is my team. In every program I conducted, Priyankur is a part of it. So it's nothing like he is calling something to his house, I feel. So thank you, Monica, for reminding me and making sure that I am there as a guest of honor in time. And we have coordinators, Dr. Bharati and Dr. Raghavendra Prasad, and my co-guest of honor along with me, Anjalakshi madam, sitting with the senior madam as a co. It's a proud privilege for me. And you have excellent speakers and chairperson and moderators, all have been introduced by Priyangur. And the topic we have selected is cervical cancer. See, it is a preventable cancer. We all know that it is the, even if whatever we do next to breast cancer, even now the incidence of cervical cancer in India is high. So to prevent it, it's very important. So one of the most important part is the screening and the guidelines which everybody should know. We are aware that it should be screened in time, but many of us don't know how it is screened, what are the methods used. All will be highlighted by experts in the first session. And the second session, when you say surgical management, most of the people know management of CS cervix means either radical hysterectomy or radiotherapy. That is what they think, chemo radiation. But there are so many, the importance of many of don't know the importance of conservative surgical methods which can be used to treat in the early stages. So one is early detection and the early stages, how it can be managed without any morbid surgeries or radiotherapy, which has many complications. So excellent topic with excellent panel. It's all the names who have been taken. So we all respect all respected panelists and experts and moderators are there. So without any delay, I know that I'm telling all the best for Priyangur for his committee and his activities. I love to be anytime when he calls to come for his activity. And I would have, if time permitted, I would have been a part of its panel. And because cancer oncology is something I also love to practice. So thank you so much, Priyangur. Thank you, Fogsi, for inviting me for this program. And thank you, Monica, also. So thank you. All the best for the program. Thank you, Priyangur.
Thank you, sir. It's a pleasure to have you with us. Thank you for your words of encouragement, sir. Thank you so much. Over to you, Monica.
Thank you, sir. Thank you for your words of encouragement. I now request Shatabdi to introduce our next guest of honor, Anjalakshi ma'am.
A very good evening to everyone. It's my pleasure to introduce our next guest of honor, Dr. Anjalakshi Chandrasekhar ma'am. Ma'am is the founder president of TNFOG. She has been the past president of OXY as well as the past president of DIPSI. She is a PhD in pregnancy diabetology from the Tamil Nadu MGR Institute. And she also has been the recipient of the Best Doctor Award from IMA. She has multiple publications and she has been examiners in various exams. She is one of the stalwarts in our field. We welcome you, Anjalakshi ma'am, and we would like to hear a few words of encouragement from you, please.
Thank you, Ma, Dr. Sadapti. Good evening to everyone. Dear President Fogsi, Dr. Rishikesh Pai, the Secretary General, Dr. Madhuri Patel, Dr. Alka Pandey, Vice President, Dr. Priyankur Roy, the Chairperson, Public Awareness Committee, Fogsi, and Dr. Kalyan, the past Chairperson, Public Awareness Committee, National Coordinator, and coordinators, Dr. Monica and Dr. Sadapti. And my dear delegates, my friend, Dr. Ramani, and my dear faculties, I am bringing warm greetings to all of you. It is my great privilege and happiness to be the guest of honor for this wonderful webinar, episode 6, a series on cervical cancer. I congratulate the Public Awareness Committee of Fogsi and the South Zone Societies for arranging this wonderful CME. And Fogsi is doing a novel performance of creating a public awareness, not only public awareness, and also awareness in the medical fraternity to give their best services to our women folk. So with the advance in the technology and science, there are advancements in the diagnostic tools and therapeutic modalities, which we have to update ourselves. And the cervical cancer is such an important topic. And this is the only cancer we can get the 100% cure and prevention, and 100% we can prevent the disease also. It is considered to be the third generation sexually transmitted disease with proper screening, prophylactic vaccine, and early diagnosis, the cancer clearance, which will help the women have a 95 to 100% survival rate. And dear delegates, you are going to listen to a talk on the guidelines of cervical cancer screening, which is a very important tool for the prevention, and also two beautiful and informative panels on cervical screening, vaccination, and the modalities on the conservative surgical management once the disease occurs. So I request all delegates to learn the advancements and offer better service to our fellow women. I wish the webinar a grand success, and also once again thank for this wonderful opportunity. Jai Hind.
Hello.
Thank you so much,
Yes.
ma'am. Yeah, over to you,
Yeah.
Monica.
Ma'am, thank you so much for your kind words of encouragement.
Mm.
I would now introduce Rishikesh Pai sir as the chief guest for this webinar. Sir has just joined. Abhishek, can we have the slide, please? Sir, thank you for joining us and being a constant source of inspiration for all of us, for being a part of all our webinars. In short, let me take pride in inviting you and introducing you for this webinar. Sir is a medical director of Bloom IVF. He is the current president-elect, Fogsi. He is also the administrator. Yes, sir.
Doesn't matter, madam. I'm not president-elect. I'm the president of Fogsi. It's the old slide. Doesn't matter.
It's a whole slide, sir.
Doesn't matter.
Yes.
Doesn't matter. Just so thank you, Priyankur, the Public Awareness Committee. Priyankur is a very dynamic person. You know, very. He was in Batok and now he's a dynamic chairman. And we are looking forward to a lot of great things from him in the future. And I can see Dr. Madhuri Patel. I don't know whether she's there. Alka Pandey ji and Kalyan Barmade, who are the other people in charge. And now I think they are doing this with the South Zone. And I can see our Padmashri Manjula Aglani is there, the great laparoscopic surgeon, and Dr. Monica Oberban, Dr. Day, Dr. Rajsekhar is there, Dr. Raghavendra Prasad, Dr. Ashwath, Dr. Anjalakshi, and then Ramani Devi I can see, who is a great endometriosis person, Dr. Baburaj, and Dr. Digmati, and many other people. Bharti Rajsekhar is already, I can see. So anyway, basically, there are like, as you become Fogsi president, then you start getting more knowledge. And so as they call you, just today I got another WHO invitation. So that's the advantage of being the president, because the federation is a very powerful organization at present. It's respected all over the world. Nothing to beat the federation. That's why everyone wants to become the Fogsi president. But even the other people who are there in the federation, there's a huge amount of opportunity. So if I understand what the world is heading towards, the two most important things they are interested in worldwide, WHO or all the other organizations, aid organizations, funding organizations. There are 5 areas of health: malaria, tuberculosis, contraception, maternal health, and cancer. These are the 5 areas the people fund. Funding areas, funding people are big. By the way, the Gates Foundation is located in Seattle. They have 1,700 employees. Do you know what is the money allocated to all these 5 things by the Gates Foundation? It's $9 billion. That's the money. The MSD for Mothers, which helps us in the Manyata program, they have a fund of $500 million. The Gates Foundation has a fund of $9 billion. So all the things that vaccines, climate change. So in the area of women's health, there are 2 important areas they are focused on at present. The world is focused on these 2 important areas. One is maternal mortality rate following childbirth. That is because of 3 things. One is the PPH, second is the sepsis, third is the hypertension. So presently the focus is on PPH. That's why as Fogsi president, I was called to the Dubai meeting or the new PPH guideline. The old guideline was done in 2012. The new guideline is coming in 2014. So when the Dubai meeting, 160 people they had called. All the researchers, etc., 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 at the bottom were the association. I was, by grace of God, called on the steering committee, which is made up of 14 people. And then they have divided this into 4 parts. First is the research, second is the advocacy, third is the guideline committee, and fourth is the implementation committee. I have been put in the guideline committee. The timeline for creating the new PPH guideline is 2024. The second part of the world is obsessed by is the cancer. So the cervical cancer is their second obsession because mortality rate on non-pregnant women is from cancer. So obviously cervical cancer is the another big baby as far as funding agencies are concerned. Whenever they look at any area, they look at it from 4 aspects: research, guideline, awareness, advocacy, and implementation, and scalability. So they will give a project to India, for example. They will analyze it in, say, Bihar, but they will sanction a project which can be applied to Africa also. It can be applied to Europe also. So scalability and application is always seen when the projects are being done. Just giving you information, what I've learned as I evolve my life, as I go up the ladder, what I have learned from them and where we should focus our energy is important. As far as the cancer, as far as my philosophy of cancer is concerned, I believe in integration, ekikaran. So I would not look at cervical cancer alone. I look at breast cancer, uterine cancer, vulvar cancer, colonic cancer, ovarian cancer, or a holistic. Holistic is important. What is the use of just being cervical cancer? You know, I remember when I was young, one of the doctors, the patient said to doctor, he examined me, delivered me, but she had a very big fungating breast because no one looked at the breast anyway. Throughout her antenatal, no one looked at her breast. So the fungating breast, I remember, and she died also. So when you look at a person, look at him in a holistic way, you know. And it's so simple. Now you can summarize cancer in 4 lines. What the big deal? Just examine a breast, do a mammography every 2 years if you have got the access, do a per abdomen and do an abdominal scan, do a cervical visual examination of cervix, do a pap smear, maybe if you have got money, do an HPV test, and do a occult blood of stools. And the new technology that is coming up is a leakage of the cells into the maternal circulation. It is a NGS, just like NIPT. There's a new test where you can analyze the cell leakage and do screen for 10 cancers. with that, and that's becoming better and better. They are becoming better. So the microRNA analysis, Dr. Ramni, they will be happy because she does the microRNA test she has done in endometriosis. So this microRNA analysis is going to be the next thing. So you will be able to pick up the cancer before actually. So you can say, okay, there's a cancer somewhere in the spleen. Let us look at that organ in more detail. So early detection, obviously, and one of the great authors, Noah Harari, has said that the longevity of women will go to 150 years because we'll be able to. So the three things that cause death in all of us is diabetes, hypertension, cardiac disease, and cancer. That's how we will die. So if we can pick them up, prevent them, and prolong, we are going to prolong our lives. So this is the new exciting field. So as far as the cancers are concerned, by microRNAs or NGS on leak DNA from cancer cells before they get clinically manifested is the way to go. And that test is round the corner. Already one lab is offering it for 15,000 rupees a year. It can pick up 10 cancers, but it will become better and better, more refined and more accurate. And I'm sure within 5 years' time, it will be a routine test, just like the NIPT has become cheap and routine. So thank you very much for calling me, Priyankur, and I'll wish you all the best. And it's an exciting time for all of us. I am also excited all the time. Since morning, I'm working. I'm on the computer. So many meetings. Just now I was called by the government for analysis of the Lakshya program. So I learned so much. You know, they have appointed a UNICEF agency which is looking at the Lakshya. How do they do it? What are the parameters they set? How is the analysis done? That's a learning process for me also, because we are not exposed to all this. We are clinicians. So this is all a very exciting time for all of us, including me. Thank you very much, Priyankur. All the best to you.
Thank you so much, sir. It's a pleasure indeed for us and encouraging every time you join our program, sir. It means a lot to us. Please do. We will invite you for all our programs, and we would love if you are there for all of them, sir. Thank you so much for your words. Thank you. Monica, over to you.
Thank you, sir, and thank you, Priyanka. I now declare that the inauguration of this webinar is over, and we now carry forward our academic session. The first academic session is a talk by Dr. Leela Digumarti ma'am. I would request the chairpersons, Ramni madam and Jina ma'am, to join the session. Abhishek, can we have the slides, please? The first chairperson is Ramni madam. Madam is the Managing Director of Ramakrishna Medical Center, LLP, and the Janani Fertility Center. She has already won 10 gold medals during her UG.
Monica, just introduce me as past VP for Fogsi, that's all.
Yes. Ma'am has been the past Vice President of Fogsi, but Madam is the most approachable person as the post holding I've seen, because we worked under the Public Awareness Committee in Environment Programs. Ma'am, welcome you to this session as a chairperson. The next chairperson is Jena ma'am. She's a consultant at Vodakara. She's a chairperson of Oncology Committee KFOG, and she is the Kerala State Coordinator of the Oncology Committee Fogsi. She's also on the editorial board of ISCCP, and she is a recognized colposcopy trainer for the same. She's also the past president of Vodakara Gynec Club. We welcome both of you to chair this session by Dr. Leela Digumarti. Over to you, Ramni ma'am.
Yeah. First of all, let me thank the PAC committee for having included me in this wonderful program on cancer screening and cancer awareness. Now it is my great opportunity to welcome Dr. Leela Digumarti, who is a gynecological oncologist from KIMS Icon Hospital, Vaishak. And she is the president of Indian Society of Colposcopy and Cervical Pathology, certified colposcopic trainer by ISCCP, member of ISCCP, Fogsi, AGOI, IMS, ISOPA, IGCS, and ISGO. And she is a DNB teacher and examiner over a period of more than a decade. And she's an organizing secretary for ISCCP 2019 National Conference, which was held at Vaishak. Since 2014, with several NGOs, she has been interested in creating awareness regarding vaccination, screening for cancer cervix by conducting regular camps in North Andhra, and master trainer for several colposcopic workshops across India. I think as on date, cancer cervical screening is the most important one. As we know already, the incidence of cancer cervix is on the decline because of our wonderful screening projects. I think it should be made available for everybody. See, like in Tamil Nadu, there has been a mobile units for cancer cervical screening, and the ANMs are even trained how to do a visual examination of the cervix by just applying this iodine, and then further they are referred to the higher centers or the taluk centers where they can undergo colposcopy and then treatment also. I think by doing this, we can definitely pick up the patients who are potential candidates for having cancer cervix at a much earlier stage, and we can prevent them. Now let us hear from the great speaker how we should go about regarding the guidelines for cancer screening. Welcome, Dr. Leela.
Yeah, thank you very much, madam, for your nice introduction. Good evening, as chairpersons, esteemed faculty. And at the outset, I thank the Public Awareness Committee of Fogsi for inviting me to be part of this wonderful webinar. And I'm really touched the way the guests and our president have spoken about importance of screening and how to evolve understanding the latest concepts and other things. So with this, I will try to spend the next 30 minutes of my understanding about cervical cancer screening. And then from then onwards, you can have the questions if I'm not clear in any aspect, and then we can move forward for panel discussion. So will you please allow me to share my screen? Shall I share my screen?
Yes, you can. Please, ma'am. Yes, ma'am. Your screens are visible. Just yes, ma'am.
Yeah. Okay. So in the next 30 minutes, I'm going to talk about cervical cancer screening guidelines. Basically, I have taken the material from our own Fogsi guidelines of GCPR made in 2018 and 2021 WHO guidelines. I have not put any other guidelines just to have a clarity. I don't want to confuse by talking about too many guidelines. So you are all familiar with this picture. That is the WHO global call for cervical cancer elimination, which was done in May 2018. So we know that one woman dies of cervical cancer every 2 minutes. Each one is a tragedy and we can prevent it. So everybody in this meeting today and those who are attending the meeting also are aware that cervical cancer is a preventable cancer. So through cost-effective, evidence-based interventions, including HPV vaccination of girls, screening and treatment of precancerous lesions, and improving access to diagnosis and treatment of invasive cancers, we can eliminate cervical cancer as a public health problem and make it a disease of the past. So that is the background on which we are all working towards elimination of cervical cancer. So again, this is known to almost everybody. This has become a common word now, that is global strategy towards elimination of cervical cancer. What are the WHO global targets set for 2030? That is 90, 70, 90. Even if somebody is woken up in the sleep, also are able to say now 90, 70, 90. So everybody knows about 90% of girls to be vaccinated by the time they reach 15 years of age. 70% of women have to be screened with a high precision test at least twice in their lifetime, that is at the age of 35 and 45. And 90% of women identified with cervical disease have to receive treatment and care. So this global call for elimination, which was started in 2018, finally came into a global call in 2020, and we have already completed 2 anniversaries and we are moving towards the 3rd anniversary. It is not just celebrating the anniversaries, but we should all aim to reach these global targets, and the time left for us is the next 7 years. So to reach these percentages. So how are we going to reach these percentages? And first of all, why should we aim to reach these percentages? That's what we have to know. So if you go into the global burden of cervical cancer, we know it is the leading cause of mortality all over the world in women. In 2020, all over the world, there are about 604,000 women who were diagnosed with new cases of cervical cancer worldwide, and 342 women died from this disease. It is still the most commonly diagnosed cancer in 23 countries and leading cause of cancer death in 36 countries. So if you see this picture, you will understand the scenario of the world. So only in Australia, you are seeing the lightest teal color, whereas in Africa, and even in the South Asia, you are seeing a darker end of the teal color. Whereas in the developed countries, we are seeing a color range between the lightest teal to the darkest. So that means there is a lot of burden globally about cervical cancer, and all of us have to work together for elimination of cervical cancer. Then coming to the Indian scenario, it is the second most common cancer in women, especially in rural women after the breast cancer. In 2020, according to Globocon statistics, it accounted for 9% of all cancers and 18.3% of new cases. Even though there is a reduction in the age standardized incidence rate in the last 3 decades, but if you really go into our population-based cancer registries, it is still the leading cause of death in 12 states, which I'm going to show in the next slide. So this is from the population-based cancer registries of India, where you see a lot of cancers of cervix happening in northeastern states of India, whatever may be the reason. And of course, in some of the urban metropolitans, the breast cancer is number 1 and the cervical cancer is number 2. So if you see here in this picture, you will understand these are the northeastern states of our country, where you see a very, very high incidence of cervical cancer. So these slides will give us an idea what is actually the burden of cervical cancer. So the incidence varies in different parts, even in our own country. It can be as high as 27.7 per 100,000 women to as low as 4.8 per 100,000 women. So if you go to the Dibrugarh district, the incidence is quite low. When you go to Pampupare district, the incidence is quite high. So it's a quite variable incidence of cervical cancer. So how to eliminate it? So if you broadly divide the elimination strategies, we know the primary prevention by HPV vaccination, which I'm not going to touch. So the next step is secondary prevention. For that, the first step for secondary prevention is screening, which I'm going to cover. I'm not going to touch upon the diagnosis or probably a little bit about treatment, where we use the screen and treat approaches. So my main focus for the talk in the evening today is screening. So what are the screening strategies and what are the guidelines? So going back to the exact topic, we are all familiar with what are all the screening tests that are available to us. So originally we were talking a lot about visual inspection with acetic acid. Even Ramani madam has stressed a lot about VIA and Willy, which really have done a lot in some states of India to reduce the incidence of cervical cancer. Then of course the Papa-Nicolau smear, that is the cytology. Then coming to the molecular testing, that is the high-risk HPV DNA testing. So in the latest WHO guidelines, the order is towards HPV as the first screening test, to the cytology, to the visual inspection. It doesn't mean that all of us would be in a position to do this high-risk HPV DNA. So we are going to see how different screening tests that are available to us can be utilized in our day-to-day practice. So coming to our Fogsi GCPR, and all of us are familiar with these guidelines, how to choose the most appropriate screening test according to our practice. So in all, almost all teaching hospitals, they do a lot of cytology. Even we were all trained to do a lot of cytology. So if you have a cytology as a screening technique, and if your lab meets the quality of indicators for the cervical cytology, you can still continue with that till your hospital or your institute or your state is ready to move on to HPV testing. Suppose if you don't have a cytology-based screening, whether you have a facility, the funding or whatever it is to move towards HPV testing. So if you have, you can move that. If you don't have that, if you cannot afford to move to any of these screening techniques, you can be still continuing doing your VIA test, which is again a time-tested test in Indian scenario. So if you are familiar with VIA, you have a good quality control over your VIA screening test, you can still continue doing it. So this is how you can choose the appropriate screening test for your practice. Then after that, our Fogsi again has recommended the available screening test based upon our resources. So if you have a good resource setting and if you have a HPV testing, you can do a primary HPV testing or you can do a co-testing both with cytology and HPV. If you don't have HPV testing, if you have a cytology, you can still continue, as I said earlier, with a good quality indicators. And then it's not just doing a test. If somebody has a positive test, we should be able to do colposcopy and biopsy. And the other modality is visual inspection with acetic acid as a screening. Then the target age group in good resource setting is between 25 and 65. Cytology can start at the age of 25, whereas primary HPV testing or co-testing is at 30. We know the reason, because we want the natural clearance of HPV to happen. So if we do HPV before 30 in a general population, we'll end up doing unnecessary further investigations and other things, and we will be creating a lot of anxiety to women. So we want the natural clearance of HPV to happen, and for that reason, we have put a cutoff of 30 to start doing HPV as a primary screening test. So if you are using HPV or co-testing, then the screening interval is once in 5 years. If you are using only cytology, the screening interval is 3 years. So if you are working in a limited resource setting, if you don't have any of these, you can very comfortably continue doing visual inspection with acetic acid. So when you are doing VIA, I don't know whether the same setting will have a facility to have a colposcopy. But if you have a referral pattern from a primary to a district hospital, VIA positives, if you are not following the screen and treat approach, or if it is not possible to do screen and treat approach, you can always refer to a higher center for colposcopy and biopsy. So the recommended age group for the screening for general population with VIA is 30 to 65. Of course, there are some problems of screening postmenopausal women with VIA, especially after the age of 55 when the transformation zone goes in. So when you are using VIA as a screening test, the recommendation by our Fogsi is every 5 years. So this is resource-based cervical cancer screening recommendations. And again, our Fogsi also has recommended when to stop screening. So we say blanket 30 to 65 years. So according to this GCPR, if you are working in a good resource setting, 65 with consistent negative results in the last 15 years. And of course, there are changes happening in all these recommendations. So women with no prior screening. So some of us usually get a chance to screen a woman at the age of 55 or 60 or 65. They would not have had screening at any time before. So in that situation, you can still do a screening test, even if you see a woman at the age of 64 or 65. So that can be done. And especially when you go for camps, you do see a lot of elderly women coming because they would come for some other reason, for medication or something like that. And you can use that as an opportunity to screen for breast as well as for cervical cancer. So follow-up method after treatment, which I'll skip this slide because we are going to discuss it in the later part of the presentation. So basically what we need to understand here is we know the types of the screening tests. The standard age that is set is between 30 and 65 years. So what does our Government of India recommendations? The Government of India recommendations, according to this, population-based screening is introduced in 2016 by the Ministry of Health and Family Welfare. So they have recommended VIA once in 5 years as the screening test from the age of 30 to 65 years. So there are a lot of importance given to VIA because it is found to be cheap, easy to do, especially in the communities and other things. But of late, it needs a lot of, it is quite subjective. It needs a lot of quality control. The person has to have enough patience to apply acetic acid, wait for sufficient time, and they should also have a good light. They should be able to identify the white lesions and all these things. So I'm not going to discuss about the methodology, but this is the standard recommended test till date by the Ministry of Health in India. Coming to the Fogsi recommendation, this is, as I said earlier, even the Fogsi also recommends VIA as one of the screening tests, especially in the limited resources places between 30 and 65 years of age, preferably is up to 50 years of age, which we have discussed earlier. So what are you going to do if you do a VIA? If it is negative, you can call them after 5 years for a repeat screening. If it is positive, what are you going to do? If it is positive, again, you can do a screen and treat approach where the lesion is visible completely and suitable for ablation. You can consider ablation, either cryo or thermal ablation. Or if you think the lesion is suspicious, then definitely you need to refer to a higher center for further management. Or if you don't want to do the screen and treat approach, then definitely again you have to refer to a higher center for colposcopy and biopsy, and accordingly the lady would be triaged. So this is the basic standard recommendation using VIA as a screening test. Even the latest WHO recommendations 2021 also say the same thing. You do VIA testing if it is negative. Here only the time interval is 3 years. Whereas in our recommendation is 5 years. If it is positive, as I said earlier, the same protocol, screen and treat approach. If you are suspecting anything invasion, then you have to refer it. Suppose if it is not suitable for ablation and if it needs an excisional treatment, if the lesion is going into the cervical canal and other things, or these are thick white or whatever it is, then it has to be sent to a higher place. So this is, I mean, if it is done in a primary setting, if in your in your own hospital, you have the facility to do all these things, you can do it. You need not refer to any higher center. So that is about the VIA testing. Coming to cytology, I mean, many places people are moving from conventional to liquid-based cytology. So whatever cytology procedure you follow, either conventional or liquid-based, the standard is, if it is negative, that means NILM, that means you have not found any intraepithelial lesions suspicious of low grade or high grade or whatever it is, you will be rescreening them after 3 years with cytology. But on the other hand, if you see any abnormality in the cytology, you broadly divide them into squamous abnormalities or glandular abnormalities. If they are squamous abnormalities and if they are low grade, that is ascus and LCIL, you can again triage them with HPV. And if the HPV is also positive, then you have to do them colposcopy. Suppose if the HPV test is negative and if the report shows only ascus, I mean, there is only slight difference between our Fogsi GCPR and this guideline. In the Fogsi guideline, ascus and LCIL can be triaged with HPV, and if both are negative, a repeat test can be done after 1 year. But in the latest WHO recommendations, only ascus triage with HPV. Anything above ascus, that means from LCIL onwards, you have to refer them to colposcopy. So if the triage test is negative, then you will call them after 3 years with cytology. If the triage test is positive, then definitely you need to send them for colposcopy. And based upon the findings, you have to manage. So I have not, there are lots of other guidelines given in the Fogsi about cytology, ascus. Individually, they have given it, but I have not, I'm not talking about those because of lack of time. I'm just going to focus mostly because basically for the cytology, the guideline is very simple in the sense you have to remember low grade abnormalities, triage with HPV. If they are high grade abnormalities, you can straight away consider doing colposcopy. Coming to HPV as a primary screening test, because of late we are talking a lot about HPV. So if you are using primary HPV testing, if it is a negative, you can call them after 5 years for screening if it is HPV positive. So if you are doing only a test where it tells you whether it is negative or positive, like a hybrid capture test, then you have to use a kind of a triage instead of just treating based upon the HPV positive report. So you can't offer treatment just by HPV positive. You have to do a kind of a triage to what kind of treatment you want to give, which I'm going to discuss in the subsequent slides. So even in the Fogsi recommendations, HPV can be used as a primary screening test. If it is negative, call them after 5 years. If it is positive, what are you going to do? Which is similar both for our Fogsi as well as for the WHO recommendations. So there used to be a lot of focus on co-testing, and of late, I think we are not talking much about co-testing. We are talking more about reflex testing. So earlier we were doing reflex HPV testing. Now people are talking about reflex cytology and other things. But some places maybe still they are doing co-testing. If you are doing co-testing, if both the tests are negative, that means smear and HPV are negative, then you can call them after 5 years. If HPV is negative and cytology is positive, so the same thing. If it is a low grade, because HPV negative and low grade smear, you call them after 1 year for a repeat test. If it is a high grade, even if it is HPV negative, you call them, you send them for colposcopy. There is a small mistake here. It is HPV positive and cytology negative. So if it is HPV positive and cytology negative, so what you are going to do with the primary HPV testing, similar algorithm you have to follow. You have to do a HPV genotyping to see whether the lady has got 16 and 18 HPV. Because 16 and 18 are considered to be the high risk, more high risk types for cervical cancer. So now with the latest DNA tests, we are trying to do partial genotyping, and we are trying to find many other high risk types also, which will be shown in the next few slides. Yeah, excuse me. Coming to WHO guidelines, there is a strong recommendation to move towards HPV DNA testing because of its sensitivity. You can do very few screening tests in the lifetime of a woman, and it is not a subjective test. So there is a strong recommendation to move towards HPV DNA testing as the primary screening test rather than VIA or cytology. But you need to have a quality controlled cytology screening, which are approved by WHO or FDA. And then only you should move towards HPV DNA testing. Otherwise, you can continue if you have a good quality of VIA or cytology. So this depends upon the facilities at that those are available at our institutes or at our hospitals or even in private sector. So to use HPV DNA testing without a triage, so especially in general population, one can do screen and treat just like VIA even after HPV DNA testing. But it is not so in women who have got HIV. So if you don't want to do screen and treat approach after HPV DNA testing, the same triage, different methods you can use to decide further whether you want to treat or not. So these are the summary of the recommendations. More or less, it is the same repetition. So start at the age of 30 years and screen every 5 to 10 years. So the advantage of HPV DNA testing, if you have done a good quality testing, even you can delay up to the age of, the interval can be delayed up to 10 years. So if you are using screen, triage and treat, also the same recommendation. So you can do screen and treat. This is basically, you need to remember, this is for general population, not for women with HIV or in an immunocompromised state. So the recommendations, there is a slight difference in the recommendations for women with HIV. Here we start screening at the age of 25 instead of 30. And here we straight away go for a screen, triage and treat approach, not the screen and treat approach. These are the two differences. And the screening interval is 3 to 5 years. Instead of 5 to 10 years, we do every 3 to 5 years because they have a higher chance of progression to invasive cancers. And you may see more higher grades of CINs in women who have immunocompromised state. So coming to other screening recommendations, especially this is applicable to use your resources in the best possible way. So priority should be given to women between 30 and 49 in the general population and 25 and 49 in women with HIV. So you can either do a provider collected sample, or of late now there is a lot of popularity or a lot of talk about HPV testing by self-testing, and which is actually happening in some parts. And I think even in southern India, especially in Kerala and Tamil Nadu, there are lots of studies happening about this self-collected samples and encouraging women to go towards that. So twice life testing is also beneficial, as we knew that 35 and 45 years. So once you have done a very regular screening after the age of 50, earlier we were talking about 65, but if you have done a good screening and a lady had regular screenings at regular intervals, and if the previous 2 screening tests which are done at 5-yearly interval are normal, then she can stop screening at the age of 50. So basically this age limit is, I don't say it's an age limit, covering this age group is why it is more important is because this is the time where the chances of precancerous lesions are more, and if you pick up and treat them, the chance of it going into invasive cancer can be reduced. So if you have the facility, if you have the funds, you can screen all women between the age of 30 and 65. So see, as I said earlier, it's not just the screening. We also need to have a kind of a follow-up plan. That's very important. So screen and treat, screen, triage, and treat. So screen and treat, again, it's very, very familiar to most of us. Most of us are doing community screening. And I know of late with the portable thermal ablators, many are comfortable doing VIA testing, VIA positive lesions. Instead of doing a biopsy, when they're comfortable doing an ablation, they're doing a thermal ablation, which can happen just in 1 minute time. And there ends the matter. So that is recommended both in our Fogsi as well as in the WHO latest recommendation. This is just to minimize the women coming to our clinics again and again, and also doing an approach where definitely it will, even though it's a bit of over treatment, but still it can reduce the incidence of progression to invasive cancer. So on the other hand, if you are using HPV as a primary testing in general population, you can also do a screen and treat approach. So in this, what you do is you do HPV DNA testing. If it comes positive, you don't know where the lesion is, but you just apply acetic acid. That means it's just like doing a VIA. And if you have seen a lesion and if it is eligible for ablation, the same thing. If it is not eligible, then you have to send for loop excision. But there is one thing, some people, what they say is, even if you have not seen the lesion, should we ablate the transformation zone or not? So that is one thing. That is probably when you are doing a simple HPV DNA testing without knowing the genotyping, you can't just ablate the entire transformation zone for all women when the test is positive. Probably if you are doing a partial genotyping test, which I'm going to show in the next triage method, there you can think of doing an ablation even if you don't find a lesion. So basically here, if you have done a HPV DNA testing, just like a hybrid capture, which is positive, you have to determine the eligibility for ablative treatment after application of 3 to 5% acetic acid with or without magnification, and you follow this algorithm. Suppose you don't want to do this screen and treat approach, you want to triage. So how we were doing a reflex HPV testing in the past, now what people are doing is if HPV test is positive, they are doing a reflex cytology because the same sample can be kept. I mean, if it is in your own hospital's lab, you can keep it and do a cytology. And if the cytology is negative, so HPV is positive, cytology is negative, you can call them back. And I mean, if it is cytology negative, yeah, and HPV is positive, you rescreen them in 3 years with cytology. Suppose cytology shows ascus. So the lady is already HPV positive and ascus. Then you have to do HPV. I mean, yeah, this is basically cytology. Sorry, this is only cytology, and the cytology we have already discussed. So cytology alone, you are using it. If the cytology is negative, rescreen. And if it is ascus, we have already discussed. So cytology, ascus, triage with HPV. And if it is HPV positive, colposcopy. If HPV negative, you rescreen them with 3 years. This already we have discussed, it's just a repetition. So here we are triaging. In cytology, I just want to emphasize that in cytology, we can't straight away do any treatment. So if you are following cytology as a screening test, the lady has to have a kind of a triage. So for the triage, if it is a low grade, you do with HPV. If it's a high grade, you can do a colposcopy. So if you are doing HPV DNA testing, what happens is if the test comes negative, fine. If it comes positive, then you can do a partial genotyping or you can do a genotyping test. You want to know what kind of high risk HPV she is harboring, 16, 18 or other high risk. So if it is 16 and 18, then definitely you have to again consider that she has got a higher chance of going into, higher chance, the risk is higher. I'm not saying that HPV positivity means they have cancer. So what we need to be is we need to be more careful to make sure that we are going to do some kind of an active intervention or keeping them under a close follow-up. So if you have done a HPV testing comes positive, then do a genotyping. If genotyping is positive HPV 16, 18, so again, you can do a VIA and as I said earlier, you can follow that. Suppose instead of HPV 16 and 18, other high-risk HPV is positive. Again, you want to make sure whether she has a lesion or not. If she has a lesion, then you can treat it. So in these situations, 16 and 18 positive, some people, what they say is, even if you don't see a lesion, because 16 and 18, it can be still a transient phase of infection. And if you don't want to leave her because of 16 and 18, maybe you can consider doing a ablation of the transformation zone. But whereas in other high-risk HPV types, you need not do a ablation when you don't find a lesion, you can keep them under follow-up. So just to make things clear, HPV 16 and 18 has got a more than 80% of cervical cancers are related to this. So we pay a little more attention when you see HPV 16, 18 positivity in the partial, in the genotyping test. I don't call it partial genotyping test. Because if you are doing a partial genotyping like COBAS or Gene Expert, you already know what kind of HPV she's having, 16, 18, 45 or other high risk. Then the management algorithm would be here. But if you're doing only HPV testing like a hybrid capture, then of course, if you want to triage, you can use this genotyping as one of the triage methods. If you other triage is VIA, we have already talked a lot about VIA triage. So the same thing here. And if you don't want to, if you want to do HPV DNA testing and either self-sampled or collected by clinician, and if it is negative, same thing. If it is positive, you can use colposcopy as a triage. So you don't want to go for cytology, reflex cytology. You don't want to do genotyping because it's expensive. You can straight away go for colposcopy. So you may find a lesion, you may not find a lesion. If the infection is in the transient phase, you may not see any lesion. If it already becomes productive and produces cellular changes, then only you will see colposcopy findings. If you see colposcopy findings, then based upon the colposcopy findings, biopsy, you can decide what you want to do. So this is, yeah, I've already covered about the cytology triage. In some Western countries, just to reduce the load over the colposcopy clinics, even if they see HPV DNA testing, if it is positive, they do cytology. And if the cytology is negative, they will call them back and do a repeat co-testing. And if it is positive, then they will call them for colposcopy. So these are all different options of triaging. So this is just a summary of the different options what we have discussed. So screen and treat, visual inspection with acetic acid, followed by treatment. HPV DNA as a primary screening test, followed by treatment. These are all in general population. Then if it is a screen triage treat, if you are doing cytology as the primary screening test, definitely it has to be triaged with colposcopy or in a low grade abnormalities with HPV testing. If you are using HPV as a primary screening test, then you have to do a genotyping. And then if the genotyping shows high risk, then you can triage. If it is a primary, instead of doing a genotyping straight away, you can do VIA triage. Or if you have a high risk HPV DNA as a screening test, if you don't want to do any kind of these triages, you can go colposcopy as a triage. And or the other way of triage is cytology. And that means you are using the available screening tests to the best possible way and want to decide what would be the best way of triaging and best way of managing that particular woman. That is what we have to understand. Well, instead of rushing every woman to a colposcopy clinic, you can triage and send them for further evaluation. So I'll miss this. I mean, I'll just skip this treatment recommendations because it is not part of my talk. If you have done a treatment, definitely the lady has to be followed up after 12 months, be it is general population, be it HIV positive women. So follow-up is very important just to make sure that the lesion has cleared. It's not just one year, you have to follow them for the next 20 years. So my take-home message is the last slide. You have to plan strategies to change to HPV screening wherever possible, to aim for screen and treat strategy wherever feasible. We have to improve the coverage and outcome of cervical cancer screening to reach the WHO global targets for cervical cancer elimination. It is the percentage of women who are covered by screening is more important than doing the screening for the same population again and again. So you have to cover a wider area of population to look for cervical cancer elimination. Thank you very much for listening to my talk patiently. And if you have any queries, please, I'm ready to answer. I hope I have conveyed some useful message to the audience today. Thank you very much.
Madam, you have covered everything. I'm Dr. Jeena Babiraj. First of all, I must thank the Public Awareness Committee for Fogsi for giving me this opportunity. And it is my honor to chair the session of Leela Digumati Madam, ICCP President, and also along with Ramani Devi Madam to stalwarts. And Leela Madam has very well explained the guidelines, Fogsi guidelines, Government of India guidelines, and WHO guidelines. And all these guidelines says we have to do, if we are doing pap smear screening or cytology screening, it has to be every 3 years, starting from 25 years to 65 years. And if we are planning to do VIA screening, that is from 30 years to 65 years, every 5 years, according to Indian screening, Indian guidelines, and the recent WHO guidelines, it is every 3 years. If we are doing this HPV testing, it is we can repeat the test after 5 to 10 years. So the sensitivity of HPV testing is very, very high. But coming to the pap smear test, cytology, the sensitivity is only around 50%. That is why it has to be repeated every 3 years. And VIA test, it is always subjective. So that depends on the result depends on the experience of the person who is doing the test. So as of now, there is no organized screening program in India. What we are doing is the opportunistic screening. So as the government is not coming up with the organized screening program. So with this opportunistic screening, we are missing a lot of cases. So if we are doing this opportunistic screening, it is better to shift to HPV DNA testing because the sensitivity is very high and the missing of cases is very low, and we have to repeat only after 10 years, 5 to 10 years. 10 years we will get 10 years. And if the lady is coming after 50 years, just do a one HPV testing. If it is negative, getting further HPV infection and precancerous conditions, CIN and CS service is very, very low. So it is high time that we have to shift to HPV DNA testing. And in Kerala, we are done this HPV DNA testing in our gynecologist, KFOG members, which is partially funded by the KFOG. And we have done the COBAS HPV testing. And around 60% of the eligible persons are done this test. But in our population also, the SPV test is possible. For the SPV positive rate is 2%. So it is there in the low risk, very low risk population of gynecologists. But in the same time, in Kerala, we have done pap smear, the cytology pap smear screening of one village. Last year, we have completed one village. All the eligible population are screened. The pap smear screening that comes around 1,500 cases. 500 ladies are screened, but there is no single screen positive with the cytology. So that shows that the sensitivity of the cytologies. So it is high time we have to shift from the cytology and the VIA test to the SPV DNA testing. And the other things, Madam has explained how we follow up all those cases. And only the testing is not much helpful. If there is positive cases, we have to treat them. Then only we will get the results. That's it. We can eliminate the conditions. So Madam has explained everything. This is what I want to say. Just this.
Thank you. I think there is
Dr. Leela, it was an excellent presentation, and Dr. Gina has very clearly summarized whatever Dr. Leela has said. So I think basically the screening should be, ideally it should be HPV based, but it depends upon the resources that is available. So it is better to have at least a VIA followed by a cytology rather than not screening the patient. So only thing is, as a part of the, as gynecologists, we must not prevent any lady who is stepping into our OPD without a examination of the breast and the cervix, because these two are the cancers which can be very easily picked up, or just a simple screening by using a speculum examination. We can further advise the patient that you need to have a cytology or you need to have a HPV testing. So that is the way, creating awareness and then proper screening based upon the economy. That is the main thing to reduce cancer of the cervix. And I think by 2030, we will be able to achieve this if all the gynecologists put our hands together. And I thank the PAC committee for giving me this excellent opportunity of sharing Dr. Leela, sharing Dr. Leela's talk. And I think I too have learned a lot. Thank you so much.
Thank you, Madam. Thank you.
Madam, one word about the cost factor, Madam. If you are in a private setup, not in the government setup, if you are doing the pap smear screening, you have to do it for a period of 10 years. Minimum 3 screening is done. Screening is needed. So around the cost, patient has to come repeatedly and all those things. That cost around for each screening, around 1,000 rupees, the minimum 1,000 rupees they have. So 3 screening in 10 years. 3,000
one screening
for a single test, SPV test, it's around 3,000 something. Yeah. So if we calculate the cost, then also this SPV testing is better, I think.
I think people are now aware about the health aspect there, and they won't hesitate to get these tests done.
Yeah. Thank you for giving me this opportunity.
Thank you. Thank you.
Yeah, thank you. I think there is one question somebody wanted to know. This one, why cryo, why thermal ablation in place of cryo? I mean, both thermal ablation and cryo are can be used as an ablative treatment, but it is easier to do thermal ablation compared to cryo, because for cryo you need to carry that nitrous oxide cylinder, the probes, and actually the cryo gun sometimes leak and everything, and the procedure also, that freeze technique takes about 3-5-3
time also.
Yeah, whereas with the thermal ablation, and we have a portable Liger thermal ablator, then VSAP thermal ablator, all these things, the time duration is only less than a minute. And another advantage of ablation, thermal ablation, is you can do a multiple applications over the, if somebody has got a large transformation zone, you can actually use different kinds of, there are different sizes of probes also, flat probes and everything. So you can cover the entire transformation zone. When you are using a cryo, you have only limited size probes, and you can't do multiple applications. Sometimes the edges may not be covered when you are using this cryo. Whereas with the thermal ablation, the coverage of destruction of the transformation zone is more. you can do complete treatment. So that's where people are preferring. And even if you want to take for camp setting, it's all battery charged. You don't need power or anything. So that's why we are moving towards thermal ablation. Even CIN2, where the IHC is negative, that means a lower grade of CIN2, you can still go ahead and do thermal ablation. So the only thing is the similar criteria. The entire lesion should be visible. The lesion should be less than 75%. And especially for a TA, even if it is a little more than 70%, 5% also, you can destroy it. So that's why that is the advantage, because there's a question in the chat box. Yeah, okay.
Thank you, madam. That was me, Dr. Bharti.
Yeah, thank you. Thank you.
Thank you so much, ma'am. Thank you, Ramni ma'am, and thank you, Jina ma'am, for chairing the session. Leela ma'am, thank you so much for an elaborate talk. You have made the job of our panelists for the next panel very, very simple. Let's move on. Let's move on to the next academic session of this webinar, that is the panel discussion on cervical screening, methods and vaccination. Our moderators for today are Dr. Bharti Rajshekhar ma'am and Dr. B. Aruna Suman ma'am. Our expert panelist is Serena Galvaz ma'am. Can we have the slides, please? The moderator, Dr. Bharti Rajshekhar ma'am, is the coordinator of the South Zone.
Monica just shortened all the introductions, so we save time.
She is the South Zone coordinator for the Public Awareness Committee, and she is a medical director and consultant at Vatsalya Hospital, Hassan.
Yeah.
She's also been the honorary secretary at Kasoga. We welcome you, ma'am.
Thank you.
I welcome our next moderator, Dr. Aruna Suman ma'am. She is the professor, HOD and vice principal at Government Medical College of the Jagitial, Telangana.
Thank you, Dr. Monica. Let's continue with the program.
21. And she is the South Zone coordinator for Fogsi 22 to 23. We welcome both of you to continue the panel discussion. I would like to introduce Serena ma'am as the expert panelist. She is a professor and HOD of the Obstetrics and Gynecology Department of the Jubilee Mission Medical College Hospital. She has been in the postgraduate teachings in the year 1994. She's an excellent academician. Ma'am has also been a faculty at various conferences. She's been the president of Thrissur OBGYN Society in 2003 and 2004. We welcome you, ma'am.
Thank you.
We have the panelists today. We have a panel of 8 galaxy stars of the galaxy who will be highlighting the aspects of cervical screening. Our first panelist, Dr. Geeta ma'am. She's a senior consultant at Mother Hospital, Thrissur, Kerala. She has been a former professor and unit chief at Amala Institute of Medical Sciences, Thrissur. She has been the president of the Thrissur OBGYN Society currently, and she is the editor of TOGS Monthly Bulletin from the year 2017 to 2020. We welcome you, ma'am.
Thank you.
Our next panelist is Dr. Prabha, ma'am. She is from Gadag, Karnataka. Her affiliations includes First Multispeciality Hospital, Gadag, which is an ADBH accredited hospital. She has been conducting IIG training courses and gynec endoscopy, and she has been elected the president of the Gadag OBGYN Society. We welcome you, ma'am. Our next panelist today is Dr. Lata Chaturvedi, ma'am. She is a professor of OBGYN and faculty of medical education, JIPMER, Pondicherry. She is currently the president of OBGYN Society of Pondicherry, and she holds an executive MBA in hospital administration. She's also done a fellowship in gynec oncology and infertility. We welcome you, ma'am. Our next panelist is Dr. Chandra Poluswamy, ma'am. She is an obstetrician, gynecologist, and an IVF consultant from Namakkal. Thank you. Well, we welcome you, ma'am. Our next panelist is Professor Archana Singh, ma'am. She is an FICOG degree and fellowship in daycare endoscopy. She is a consultant at Yashoda Hospital, Hyderabad, and Basant Sahni Hospital, Hyderabad. She has been the secretary of Hyderabad Society in the year 2021. She has been had a brilliant academic career with a gold medal in MBBS and has received many accolades. We welcome you, ma'am. Our next panelist is Padmaja, ma'am. She has her fields of interest, including high-risk pregnancy, gynec endoscopy, and preventive healthcare of women. She's a senior consultant gynecologist at Adarsh Hospital, Rajamundry, and currently she is the president of the Rajamundry Obstetrics and Gynecological Society. We welcome you, ma'am. Our next panelist is Dr. Amruta Ramachandran. She is the Additional Professor of Obstetrics and Gynecology at Government Medical College, Kozhikode. Our final panelist is Dr. Rupa Prakash, madam. She is a former professor and unit head of the JSS Medical College, Mysore. She is also a senior consultant at Apollo BGS Hospital and Kamakshi Hospital, Mysore. She has been the former secretary of Mysore OBGY Society, and currently she is the president of the same society. She has a teaching experience of almost 20 years. I'm sure with these faculties, we will be enlightening all the delegates to a very, very smooth process of cervical screening. We welcome our moderators to carry forward the session.
Thank you, Dr. Monica, for this introduction. And I, at the outset, would like to thank Fogsi, President Dr. Rishikesh Pai, and the Public Awareness Committee Chair, Dr. Priyankur Roy, for giving us this opportunity. And I would say that I'm indeed privileged to have the doyens like Dr. Ramani Devi, Dr. Anjalakshi, Dr. Jeena over here. And Dr. Leela has made our job very easy, and most of the answers are out for the panelists. So without wasting much time, I would like to share my screen and we will go to the panel. Can I share my screen now?
Yes, ma'am. You can, please.
Yeah. Is it visible?
Yes, ma'am. It is visible.
Yeah.
Just make it full screen.
Make it slideshow. Yeah, just a minute. Just give me a minute.
Yes, ma'am. Screens are visible.
Yeah, I just let me make it slideshow.
Yes.
Right. Yes, fine. Sorry for the technical glitch. We have been talking about the cancer cervix Mukta Bharat, and
Madam, it has not become a slideshow yet.
Not yet. It's there on my screen as slideshow.
Yeah, but not in us in the common display.
Okay. Do I need to stop it and go back again?
Ma'am, actually your this Microsoft PowerPoint version is low. This is a technical problem. So you can share the screen without making it slideshow, ma'am.
Okay, fine.
This is a technical problem from Microsoft end.
Okay, sorry. So let me share it again, right?
Just share the screen. Don't make it slideshow, ma'am.
Okay, fine. Is it now? Is it same? Is it okay?
Yes, ma'am.
Fine.
It's fine.
So can I go ahead?
Yes, ma'am.
Yeah. So, well, we have a luminary of panelists with us over here, and I thank Dr. Aruna Suman to be my co-moderator, and Dr. Sarina, who will be the expert here to take us through this very informative and very useful panel. I'm not able, my slides are not moving.
Just click on the in between, ma'am, one time, and now try to move the screen.
Yeah.
Yes, ma'am.
Well, the burden of cervical cancer, all of us are familiar with, and for paucity of time, I will be skipping. We know that in India, almost one woman in 8 minutes is tested positive, and we contribute to almost 23% of the cancer cervix deaths. But do we have hope for these women? Let us see what our panelists have to say. So, Dr. Archana, how could we reduce the burden of cancer cervix in India?
We know, good morning, everyone, and thank you, Public Awareness Committee, for giving me this opportunity, and thank you, Fogsi, for giving us so much of opportunity and for learning and discussing. The question is, the cervical cancer, the load can be prevented? Yes, the load can be prevented not only by screening, but by vaccination also. We know that prevention is the best cure. But when it comes to cancer cervix, most of the time, unfortunately, we diagnose when the time is too late to prevent it. So why not start early and start vaccination? The lifestyle modification, as such, the government and the Fogsi has done very good step towards the encouragement for increasing the age of marriage for 21 years also. But still, even GSK scheme and all, the marriage age and early pregnancy has reduced. So overall, we are on the right track. And vaccination, if it is given on school basis also, probably will be reducing the cancer cervix burden. The aim is 90, 70, and 90. 90% of the girls should be vaccinated, 70% should be screened, and 90% cancer should be treated. We can do it only if we do all the 3 steps, and one prevention is better than 10 corrective measures, and 10 corrective measures are better than, and they cannot compare with one life saved. So we have to work hard and we have to work fast.
Thank you, Dr. Archana. I now request Dr. Aruna Suman, my co-moderator, to take over. Dr. Aruna, please.
Thank you, Bharati ma'am, for this opportunity. I feel very happy to be your co-moderator. Thank you, Hrishikesh Pai sir, Alka Pandey madam, and Priyankur Roy for this opportunity. Continue with the panel. What is the most common cause of cervical cancer? Dr. Chandra Ponuswamy, can you please answer?
Yeah, at the outset, it's my privilege to thank Public Awareness Committee, Dr. Priyankur Roy, Dr. Monica, Dr. Sadapti, and chairpersons Dr. Bharati, Dr. Sumana, Aruna, and Dr. Gilwas. Then, as we all, after the speech, and we know that HPV is the most common cause, which produces almost 100% is the cause for the cancer cervix. I mean, though there are more than 100 types of HPV are available, few types are more oncogenic. HPV 16 and 18. It produces 75% of cervical cancer and more than 50% of vaginal and vulvar cancer. But the non-cancer producing types, HPV 6 and 11, they are the cause for anogenital warts, 90% of anogenital warts. So the culprit is HPV. We have to treat HPV. Then there are various types of papilloma virus. Certain types affect the skin, cutaneous aspect, and certain types affect the mucosal type, which the virus which affects the mucosa, even that 16 and 18 are the most oncogenic property. And how these HPV virus, once they enter the epithelial tissue, they get replicated. They enter into the epithelial cells, they get replicated, then they stay there for quite some time. As Dr. Leela said, it gets spontaneously gets healed, but in course of time, another 10 to 30 years, in less, if they get more and more repeated infection or in immunocompromised persons, it takes into form of precancerous and cancerous lesion.
Thank you, madam. Now, Dr. Geeta, is it possible to get ourselves protected from cervical cancer?
Good evening, everyone. At the outset, let me thank the Public Awareness Committee. It's my privilege to be part of this session. Yeah, and to answer your question, ma'am, yes, to a very large extent, it is possible to protect our population against human papilloma virus infections and CS cervix, ultimately CS cervix. So as madam said, it is caused by HPV virus. And if we see the cycle, most of it gets eliminated within 1 or 2 years, but the ones which remain are going to cause the progress to CS cervix. So if we can catch at the point before the HPV infection becomes rampant, or at the time when it is causing low-grade lesions or changes in the cells, then that way we can probably prevent it progressing into CS cervix. So vaccine prevention is probably the best one, but if not possible, then probably screening would be the next step that we can. So primary as well as, I think primordial prevention already Dr. Previously told. So this thing will be vaccine as well as the secondary prevention by screening. So we have a lot of time. Actually, we have a lot of time in between where we can catch before it develops into CSR.
Yeah. So what are the types of HPV vaccines? Dr. Aruna Suman, you can take it forward. Dr. Amruta.
Yes. How do HPV vaccine prevent cancer cervix? Dr. Amruta, can you elaborate on this, please?
At the outset, I would like to thank the organizers for giving me this opportunity. HPV vaccine prevents CS cervix by active immunization. So virus-like particles are released into the system, which stimulates the active immunization, antigen-antibody reaction occurs, and antibodies are produced, which once it starts circulating in the system, will be able to neutralize whenever the virus enters the body. So that happens to be the mode of action of HPV vaccine.
Dr. Aruna, you can take the next question.
Okay. Dr. Lata Chaturvedula, how many types of vaccines are available now?
Yeah, it was 3 now. Thankfully, India has produced one more. So we have Cervarix vaccine, which has mainly 16 and 18 against the oncogenic HPV. Then we have Gardasil 4 quadrivalent, which also is against warts. Now the question is why warts have to be treated. It may not produce cancers, but again, yeah, it may interfere with the sexual activity. So that is also very important to treat the warts. Then now we have Gardasil 9, which has not just 16, 11, 16 and 18 and other oncogenic numbers like 31, 32, 45, 52 and 58. What India has brought out Cervavac, which is already available in certain metros, but with a cost of 2,000 rupees. That's again a quadrivalent vaccine, which has all 4, 6, 11, 16 and 18.
So which one do you prefer?
Whichever government can give me free of cost, at least the quadrivalent vaccine, which is cheaper. I mean, which is cheaper among whatever is available, but definitely is quadrivalent. If not, at least something to prevent the oncogenic viruses, that is 16 and 18. Preference for me, being in a government setup, it's always whichever is the most cost-effective one.
I think government is making one vaccine which is available for 200 to 400.
Yeah, that is
single dose vaccine. It's going to come up in future.
Yeah, I know. That's what, but right now what is available is 2,000.
No, I think right now Cervarix is off the market. Could I interrupt? Cervarix is out of the market now. Yes. We only have Gardasil 4 and Gardasil 9. But hope for the indigenous vaccine is it is going to be 2,000 a vial, which contains 2 doses. So it's going to be around 1,000 rupees. That is what the latest news.
Yeah, that is if 2 people can share it.
Yeah, and probably by April, I think, by June, we hope that it will be introduced in the National Immunization Protocol. So, Dr. Lata, I am sure it will be available free of cost for all our girls.
Yes, thank you.
So now, Dr. Padmaja, how are the doses scheduled?
At the outset, I would like to thank Fogsi and the Public Awareness Committee. I feel extremely privileged to be part of this wonderful program, madam. And coming to the dosage schedule, it's wonderful to have a vaccine. And in fact, the cancer with vaccine is the only vaccine against a cancer of all the malignancies. And dosage schedule below 14 and below. The girl or the child needs only 2 doses given at 0 and 6 months.
If she is less than 15 years.
Less than 15 years, 0 and 6 months. Above 15 years, we have to give 3 doses at the schedule of 0, 2 and 6. This is the standard dosage schedule what we follow. If they have missed some time, suppose if they have not taken the second schedule by the end of 2 months, we have to see that the 3 schedules are 3 doses are finished within a year. The immunogenicity and antibody, the level of antibodies evoked are almost in par with the standard schedule. And the age group which have to be vaccinated, the best age to target is the age 11 to 12 years. That is the best age. And the reason,
and the maximum coverage can be up to?
Actually, according to the Indian FDA guidelines, up to 45. And of course, internationally, they're recommending up to 26 years.
Okay.
I think, Aruna, that's coming later, I think.
Okay, sorry.
No, it's okay, it's okay. Yeah, next.
What is it essential to start the schedule at, why is it essential to start the schedule at 9 to 10 years? What is the advantage? Dr. Prabha Desai?
Prabha, are you there?
Hello.
Yes, Prabha,
she's
please
there.
go
Yes.
Are you listen to me? Hello. Am I?
Yes, Prabha, please go on.
Yes, Dr. Prabha, continue. Go on.
You're not audible, Dr. Prabha.
Now?
Yeah, now you are. Yeah.
Now?
Yes, now please go ahead.
See, the age of starting this at early age, the advantages are very good because of the young age and the adolescent, their antibody formations are of very good quality and they are very high levels of antibodies which they reach at the young adolescence age. And second thing is, as they are not yet exposed to the HPV vaccines, in the form of sexual contact and all, the efficacy is more at this age, and also cost of the immunization is less in most of the adolescents who just needs 2 doses at below 14 age, and above that we have to give 3 doses. So considering these all 4 important advantages of giving the adolescents at 9 to 10 age, I actually not only gynecologists, I think all the pediatricians have also started in their routine vaccination schedule and giving the options to the mothers.
Yeah, thank you, Dr. Prabha. So we need to start early because only 2 doses we save money, and they're more receptive in adolescent when the pediatrician tells them to take a vaccine rather than the gynecologist telling them. So, Dr. Rupa, what are the protocols in special situations like pregnancy, lactation, immunocompromised, etc.?
Thank you very much for including me in this panel, Bharti, and thanks for the opportunity, Monica. There are several situations where you may have to differ, but most often, especially in women with HIV positive, it remains the same. And then supposing they miss a dose, so wherever there is interruption, you continue with the rest of the dose and complete it within a year. In pregnancy and lactation, it is not recommended, but nowadays they say in lactation, you can go ahead with the vaccination schedule.
Postpartum period.
Yeah. And victims of sexual abuse, of course, 3 doses. Initiate preferably at the time of examination at healthcare facility. Women with history of abnormal screening report. You have done a screening test, they're positive, but go ahead with vaccination because it offers you protection, same age recommendation. And in India, still male has not been licensed, so it's only for the female, though they are also the carriers and they also pass on the virus to the female, it's not yet. So lactation, they can, but in pregnancy, it's not recommended.
Yeah. Well, Dr. Archana, now coming to boys, do they need to be vaccinated?
Yes, of course. It is needed not only because it prevents cervical cancer, it also prevents vulval cancer 70% and 75% of vaginal cancer. But for boys, 90% of anal cancer and 75% of penile cancer can be prevented. So it is high time that we realize that 60 to 70% of penile cancer and 90% of anal cancer can be prevented by giving this simple vaccination, which is same that below 15 years, 3 doses we can give. 15 to 21 years, we have to give 3 doses, and then 75, and then we have to offer them not a compulsion, but 21 to 26 we have to offer, and 26 to 45 they can, although it is not recommended, but it is better to take, particularly in our setup where the screening and prevention can bring forth the reduction in penile cancer and anal cancer also.
Yeah. Madam, Dr. Sarina, our expert, I have a question. Because it is not yet approved in India, if some parent comes and asks us to give the vaccine to the boys, can we do that?
I think to answer your question, Dr. Bharati, I feel that you said some time back, isn't it, that by April, you're going to get the government of India to include it in the vaccination protocol. Probably we should wait for that landmark before we promote it to the boys.
Yes, because so right now, girls are a
right
priority.
Now we don't, exactly.
In our setup. Thank you, madam. So now, this question is to Dr. Chandra. Yeah, someone has received at the age of 9 to 14 years, they received 2 doses of HPV vaccine less than 5 months apart. And should you give them the 3rd dose?
Definitely, because the interval should be at least 6 months. So if they've given before 5 months, maybe the 2nd dose would not have acted. So we have to give the 3rd dose.
Yes.
And even if the 2nd dose is given earlier than 5 months, 4 months, 3 months like that also, then we have to repeat the 3rd dose.
Yeah, this we're going to skip because Dr. Rupa has already answered this question. Yes. So now, Dr. Geeta, there is Miss B, 19 years. She's taken 2 injections of Cervarix, and then now she is coming for her 3rd dose. But however, Cervarix is off the market now. So what are her options?
Yeah, any vaccine which is available can be used, and the same schedule should be continued. That's all that is important. So she can complete the schedule using whatever vaccine is available in the market.
Yeah, that is the message I think we wanted to go through. Well, Dr. Hema is been replaced by Dr. Amruta. So there is Mrs. S, 38 years. She has HPV screening done. It's negative. She does have a family history of cancer cervix. She wants to get vaccinated. Guidelines say that the international guidelines, not the Fogsi guidelines. So what precautions will you take before you counsel her for the vaccine? What would you tell her?
The problem here is she is 38 years. So the ideal age would have been between 9 and 14. So she has completed that age group. And the efficacy of the vaccine in this particular age is not as high as in the pubertal age group, because the woman may already have been exposed to an HPV infection. And besides that, I think preference at this age group should have been to screening rather than vaccination. And she will require 3 doses. So
she has been screened, but then she says, I would like to take the vaccine too.
Yeah, of course.
Yeah, of course. So then you have to give it to her, but before that you have to counsel her and tell them that it is not going to be 99% the protection, and she has to tell them that the efficacy may be less, and she has to continue with the screening procedures as per the schedules of the national guidelines. Thank you. Dr. Aruna, you can
continue with that. How to counsel for vaccination, Dr. Lata? How do you counsel?
Yes. This is a bit difficult, especially when it comes to HPV, because when we say HPV, cervical cancer and all, people will get alarmed. So better not to tell them that, give too much of information, scientific information, and say this is because of sexual activity and, multiple sexual partners and all those things. I would like to relate it with the vaccines which prevent diseases which already children would have got earlier. Maybe that will be more receptive for them to take it. And as someone has already told, include it in the universal immunization program, so they take it, okay, this is natural for everyone to take, and it will be better. I feel that way it will be better rather than giving them too much of scientific knowledge. And try to keep the daughter also with them and make them understand, at least tell them that there is a malignancy which is being affected, which is because of this particular thing, which this vaccine will definitely sort of bring down the incidence of cervical cancer, which is very common. That's how I would like to counsel the patient.
So this is a good slide showing how exactly to counsel. Ensure right choice of words like today, prevent cancer, keep healthy, protect, we, I, our, together, benefit, love. And words and phrases to avoid percentage, immunity, sexually transmitted, and promiscuous. This is a very good slide that Madam has made. Very
Thank
nice.
you so much. Thank you, Aruna. Yeah. So
Yeah,
let
can
us
I
move
just
on.
add one point?
Yes, please. Yes, please.
Yeah, nowadays with this corona and corona vaccination, it has become very easy to counsel women about, the families to take this HPV vaccination because like the government has really done a good job of vaccinating crores of people against corona.
Yes,
so now the counseling has become a little easier. Of course, we never say that it is a cancer vaccine. And like how coronavirus causing COVID, we say this HPV virus causes many cancers. And like how you have taken vaccine to protect you against COVID, this is a vaccine to protect you against HPV infection and other things. And I think I don't find that difficulty to counsel people against HPV vaccination and other things. And this has made our job very easy nowadays, and people are really understanding it.
True, madam.
And one more thing we can always tell is now Government of India is sort of promoting, and it is going to give us at a low cost, I would say, may not be free.
Or free of cost.
Yeah. Or free, whichever.
Yeah, one more thing I want to add, because in obstetrics, when we are like family, we are teaching their family, so from childhood itself, we'll be seeing the girls. So the mother easily get confidence in us, and they take the injections easily. They don't deny.
Very true. Very true.
Yeah, Dr. Bharti, if I may add one thing.
Yes, madam, please.
The best way to counsel them would be just tell them this one thing, that this is a very common cancer in India. It is the commonest genital cancer, and it is totally preventable by the vaccination. Just that. I think with that, they will take it. We don't have to tell them how is the mode of transmission. She can also get it from her husband, right?
Exactly.
So that we don't have to.
Madam, in my hospital have a very small flyer in the vernacular, in the local language, which I give it to everybody who walks inside, and that I will display at the end of my presentation. So that makes them understand, and they come back and ask us for the vaccine. Give it to the mother, she comes back with the daughter. So let's move ahead. Dr. Padmaja, there was a lot of talk about when the safety of the vaccine, and a few years back, there were a lot of rumors in the newspapers.
Yeah.
What about the safety protocols?
It was in fact a very eye-opening. Initially, when the Gardasil was introduced and when clinical trials were happening, there was a lot of hue and cry that some tribal girls, they had experimented on some tribal girls, and that was the cause of death of some girls.
Especially at your
the
place.
studies went on.
Dr. Padmaja, this happened at your place.
Yes, madam. Yes. So finally, the clinical trials were on, and it came to the awareness. It created awareness, lot of public awareness, and there are enough studies today to tell that the safety profile of the vaccine is very, very favorable and very acceptable safety profile. Most of the reactions are very minimal, and just they include the mild local reactions like redness, some pain and some swelling, like any other injection. Very few people who have the fear of injection or something like that, who have that injection phobia, they might have things like some reeling sensation or syncopal attacks. For them to avoid that, it is better to ask them to lie down and give the injection. And just observe them for half an hour and send them after half an hour. That's all.
It's very safe to use it.
Another thing, Dr. Aruna and Padmaja, what I do is I personally give the vaccination to these girls. They're very confident. I don't make my nurse give the vaccine. So they're very
Same
happy.
here, madam.
Yes.
Same here. Even I do.
That makes a difference. That makes a
Yes.
difference. You just talk to them and give it to them. It's fine.
Yes.
And because it's expensive, they are very happy that the gynecologist has given it to them.
Yeah,
exactly.
So now I would keep this question to all the panelists. What can we do to get this 90% target in India? We can add on, and then we'll move to the next part of our panel and move it along faster.
We need a lot of awareness programs.
Yes.
Basically, lot of awareness programs. That is most important. And from the level of schools, the parents have to be created awareness. The school children have to be created awareness, and there should be awareness programs in all private schools as well as the government schools. The teachers have to be aware to convey the message to the kids
Dr. Sarina and Dr. Leela, madam, can you add to this as experts?
What is it that you wanted?
How do we achieve this 90% target of vaccination in our country?
Yeah, exactly what you said, Dr. Bharati. That is the most important thing. And it is so achievable because if you make it a vaccination protocol in the national vaccination protocol, it will just glide along. Before they leave school, everyone, boy and girl, should be getting this vaccination. I think we'll achieve more than 90%.
Teachers
and that time it will be
parents.
affordable also, I think.
Yeah. Teachers and parents need to be educated more than the children, because they have to motivate them.
I want to add here, Dr. Rupa, I think initially, I mean, many gynecologists, sorry to say, still do not talk about the vaccination.
Yes.
We have to catch on every opportunity, and to the general practitioners, to the IMA doctors, to the pediatricians, talk about HPV vaccination and screening.
Even the staff in our departments also and the wards, they, the doctors, staff, everybody, if they are counseled, then that forms a big group.
Yes, madam. So see, there are these states of Punjab and Sikkim, in spite of it being a paid vaccine, have given it, have ensured that it is there. And so if we have a will, there is always a way, even if it is difficult. We just have to find a pathway for that. So now we move on. Dr. Aruna, please take over.
Okay, let us come to screening part of this. What is screening? What are the criteria of ideal screening methods?
I think Dr. Prabha,
can someone take over? Please let us be quick.
Yeah, be quick. Dr. Prabha, please.
See,
Screening ideal.
Please
not audible.
Come closer to your mic and speak.
Remove your earphones. Remove your earphones. I think she's using headphones.
Okay.
No, she's not audible. Somebody else can take the question.
Yeah, an ideal screening method should be very simple.
Yes.
High sensitivity, high specificity, cheap, easily available, and accurate. And depending on that, we should be able to give a solution to the patient, whether she needs further treatment or does not need anything, just a follow-up.
Yeah. Thank you, Rupa. Dr. Prabha, you can take this question.
Yeah, 1 minute. Am I audible now?
Yeah, now you are, please.
Okay. See,
what are the different methods?
What are the different methods of cervical cancer screening?
First foremost is very old standard is pap smear screening, followed by nowadays most recommended is HPV screening, and along with the pap smear screening, that is a cytology, either liquid-based cytology or regular pap smear is also.
Oh, she's still not audible.
You're not audible, Dr. Prabha.
Shall I?
Yeah, just somebody else. Yes, somebody else can go ahead.
It's conventional cytology, molecular study, HPV, then visual inspection. So all these three methods we can do. So cytology, as Dr. Leela elaborately told, cytology was the conventional pap smear. Then if they are affordable, we can go in for HPV DNA testing. Or sometimes instead of cytology, they go for lipid-based cytology also, HPV. Then low settings, we can do VIA or VILI inspection.
Which are the methods that are followed widely now? What are
Pap
we using?
smear. Pap smear is widely followed still.
In some of the primary health centers still, in at least in Tamil Nadu, we get a lot of patients who get a VIA done and they are referred. So it is actually working quite well for us. So at least we can directly do a colposcopy or cytology depending on what it is. Of course, in institutes, I think most of us follow pap smear, conventional pap smear, and now we have all moved on to, most of us have moved on to liquid-based cytology.
What about the panelists in the private sector? Can they tell me what they follow?
Pap smear.
It is liquid-based cytology and if affordable, HPV testing.
I am able to do my HPV with hybrid, with the high-risk groups with a very concessional rate. I already put it in the chat box. Somebody said it's 3,000. I do it. I have been working with the companies and I have got it for 1,000 rupees. And I've been doing it for the past 5 years.
He doesn't agree to do it for 1,000 here in Mysore.
No, if you increase your numbers, your numbers, Karkinos and Roche are ready to do it, and they do the high-risk screening also.
Correct.
So the pros and cons of pap smear are always there.
Yeah.
So I think we will move ahead.
Yeah.
Yeah. So how is Dr. Padmaja, how is the PAP test result interpreted? Very important. It's getting it done. No, we have to interpret it.
Yes. Now, there has been a subtle changes in the terminology from the year 1988 when it has been introduced, madam. But grossly, what is, if the lower 1/3 of the cells are involved, it is very mild disease. If the lower 2/3 are involved, it is moderate. More than 2/3, it is severe disease. And hence the treatment varies. And the treatment varies depending on a lot of
Yeah, somebody needs to mute.
Please mute.
Mute.
Every one of you, please mute.
Yes. Currently, what we are following is the Bethesda or updated WHO. I'll just come because there can be difference in the reporting system of the pathologists depending on what they are used to. The earliest or the first one is the negative intraepithelial lesion or neoplasia. For negative intraepithelial lesion or malignancy. So these are the cells. When the slide shows no cells with cellular changes or inflammation, this is the NILM.
Yeah, so basically, we have to go by the Bethesda system. We need to ask our pathologist if that is what the standard of care is nowadays.
Yes, because that is updated WHO system.
Yes.
And that's what we need to follow. Next,
I think let's move a little faster.
Yeah.
I hope the panelists don't mind. Dr. Aruna, please go ahead.
Yes. What are the limitations of PAP? Dr. Geeta?
Point-wise,
please.
Yes, please be short.
PAP depends on the quality of the smear. And so it has got a poor sensitivity but high specificity. So there is a chance that we are going to miss quite a few cases of there may be false negative. So false positivity may be things. So high. So there are high. So it needs to be results need some time. So and it needs to be repeated every 3 years. Not see the probably that get it. So it will be difficult to do in such patients. But still, in spite of all that, Pap smear still remains the mainstay of screening. Am I audible?
Pap smear, when to start and how often do we do? Dr. Archana?
Hello? 21 years and above 65 years not to do. 21 to 30 years every 3 years. And 30 to 65 years, it is every 3 years when it is PAP test. And when it is HPV, we are having good margin, and every 5 years, it is enough.
Yeah, thank you.
But 21 years, do we start in India? I think it is 25 as recommended by
It's not 21, madam. It's 21 now. We start after that, depending.
It's written 21 to 30 years PAP smear. That's what I'm saying. Even PAP is recommended
25
and above.
25. 25.
Upon the sexual
in place of LBC?
Yes.
Does it score over the Pap smear?
Yes, liquid-based cytology, it scores in this in the way that the quality of the smear is much better. The background will be more clear. Unnecessary cells will not be there. And actually, the sample is taken and put inside a thin prep vial, and the unnecessary cells can be filtered. And it can be also used for reflex testing. So in this way, liquid-based cytology scores over the conventional method.
Thank you. So how do you manage following screening? Dr. Leela has very wonderfully told us.
Yeah.
So we just run through this.
Yes.
Dr. Chandra?
Yeah, when the results are positive, when we divide into it is negative, then a rescan after 3 years. Whether it is low grade or high grade ascus or more than ascus, directly we can go into colposcopy. If it is doubtful only, then we have to do triage, screen, triage, and then treat. So even with triage, if it is negative, then again leave it and then rescan after 3 years. If it is positive, then go for colposcopy, then treatment accordingly.
Yeah, thank you, madam. Dr. Rupa, what does the recent guidelines say?
Guidelines says that we have to do co-testing. That's the best. Pap smear with HPV testing, which is most accurate, done every 5 years.
High risk HPV DNA.
Yeah.
Every 5 years. That's the WHO. Depending on the resources available.
Of course.
I think we'll have to modify that.
Yes, yes, yes.
So, which method, Dr. Prabha, if you are there, all right, with your voice? Because there are many numerous, the market has been flooded with a lot of HPV tests. Everyone comes and tells us, and each one has got a very high cost around it. So, what would you say? Anybody can take the question if Prabha is not there. Dr. Archana, Dr. Rupa, Dr. Geeta, Dr. Amruta. Anybody, please?
The problem with HPV testing widely used is that most of them are not standardized.
Yes.
So, if the standardized ones like COBAS and OnClarity, now they have the provision for doing genotyping also.
Yes.
So, whatever is available and standardized, I think it should be done.
Yeah, this is what I use
COBAS,
in my practice.
COBAS 4800 by Roche.
Which is, by Roche, and that is what I am getting at a very subsidized rate. I think all gynecologists and societies need to talk to them, give them more numbers, they will come down in the price, because I have been successful in that.
Okay.
Yeah.
Thank you.
And I'm passing on the benefit. So what is the HPV? Self-sampling kits, as Dr. Leela Madam already told, Kerala has been doing a wonderful program on this, and this has picked up in a very big way. And I think we need to present this also to our women who are very apprehensive to get it done sometimes, and gynecologists. This study was done in Kerala, I think, where all gynecologists were given a kit of the self-testing kit, and they came back with the reports. So the pros and cons, these all tests don't come without any advantages or disadvantages. Dr. Padmaja?
Yes, we have to remember one thing, that HPV DNA testing predicts only that the woman is infected with HPV. It doesn't predict that she will develop cancer or any other precancerous lesion. And another thing very important is 90% of the HPV infected women revert back to normal, because it's the body's healing, unless they're immunocompromised or whatever. Only 10% of them progress into the cancer or precancerous lesions, depending upon the HPV serotype which they're infected. So, because once they're tested as HPV positive, there is always chances of unnecessary anxiety of the patient, of the doctor, of more interventions, more risk of surgical intervention and over treatment. These are all the risks of a woman diagnosed to be HPV positive. Another thing is, it only diagnoses the HPV infection at the time of testing, not either the past, or neither does it predict the infection. And it also does not throw a light on the abnormal cells or the cellular changes which happened in the cervix at that moment of time. Therefore, hence, once HPV DNA positive, these women always should be subjected to further testing for the cellular changes in the cervix.
Yeah. So,
Dr. sorry to interrupt, ma'am.
Shall we stop? Yeah, I know.
Ma'am, we can just take home messages and we can end, ma'am.
Yeah. So I'll just go to because Dr. Leela has very wonderfully put this. Recommended Madam has put this, the VIA and VILI in the low resource setting. So I'm not going to go into that. Madam has told us that we can go ahead, and how do we follow? So we will just move to the.
Hello.
Yes, Madam. Prabha.
Yeah, sorry. Something has went wrong with my spine.
Your earphones, I think. So, well, just to for completion, Dr. Archana, what are the other methods available other than the regular PAP, VILI, VIA, and HPV tests?
The messenger RNA, E6, E7, the protein biomarkers. The advantage is they are having, say, if it is HPV tested, and then also we can rule out, and but the cost is too high. So it cannot be used as a screening method, but the future is really good. With less intervention, we get more number of cases and more specific, the protein biomarkers as well as the messenger RNA.
Yeah. So,
and 16, 18, 34, 35 can be seen with them.
Madam. Yeah. So this madam has already spoken. So we're just copying the protocol for and what we do after that, the place of co-testing. I'm not going to go into that. So when do we stop screening, Dr. Padmaja?
Yeah. To put it short, we can stop screening if the previous PAPs have all been normal. We can stop screening by the age of 65. if the woman had never done any pap smear earlier, we need to do a proper, well predictive pap smear at the age of 65. And if it is negative, we can just avoid any further screening or anything. We can tell her services she doesn't need any screening further. But if it is positive, we need to go ahead with the standard protocol.
For hysterectomized patients,
yes,
please.
I wanted that point.
Yeah. For hysterectomized patient, first of all, if a patient comes with telling that she has undergone hysterectomy, we should be very sure whether it is subtotal, where the cervix has been retained, or it's a total hysterectomy where the cervix has been removed. And we have to confirm with the reports and her histopathology report. If the histopathology report of her specimen at the time of hysterectomy shows it has something like a sin lesion or something, then she has to be subjected to a cytological evaluation and HPV testing at the end of 6 months and the end of 18 months. If nothing is there, I mean, in the histopathology, so the cervix is normal or something like that, it has been done for some other indication like fibroids or something else where the cervix is normal, then we can just say you just don't need to any screening. But she can always come back if she has any symptoms, because other things like vaginal cancer or vulval cancer can be there in rare occasions.
Yeah,
if
the
she
point
has some
is,
bleeding baby, she needs it.
even if they have hysterectomy, kindly do a clinical examination of the perineum and the vulva and the vagina, irrespective of their age and irrespective of their hysterectomy, because most often they will not have their reports.
Yeah.
And
Yes.
we must miss
Correct. As a gynecologist, never to miss a lesion in the vulva, vagina, vault.
Yes. Yeah. So we know that cervical screening, whatever has to be done, and we can prevent cervical cancer. And so whatever the barriers we do have. So at last point, I would like the panelists and the experts to give their take home last one message from each one.
At least do some kind of screening, whatever possible, whether it's HPV, cytology, or VIA, doesn't matter. At least do a speculum. If not, I mean, that is something which we should train even our primary health center workers, healthcare workers. That's what we feel.
Take the opportunity to of the CA cervix patients family to to spread the awareness about this vaccination and preventive measures in the society, because the sufferers can become more propagators for the preventive measures. This is what I do in my practice.
That's the
For me, it is each one teach one.
Yes.
So you teach one person and tell them to tell their friends and relatives to go ahead with screening and vaccination, everything they should do. So each one should teach one.
Yes, screen each and everyone who comes for some other purpose also to your clinic, and the mothers of delivery patients, everybody, and make awareness and take screening for them.
Dr. Sarina Madam, as an expert, I would like you and Dr. Aruna Suman to conclude the panel. I thank all my panelists and the organizers for giving us the opportunity, and sorry of taking about 7 minutes extra.
Yeah, first of all, I must say it's a good show, Dr. Priyankur and Dr. Monica, excellent moderators, Dr. Bharati and Dr. Aruna, and all the panelists. If I'm going to be very harsh, I must say one statement. Time has probably come, and it will come shortly. We'll be dropping the pap smears, and we must take up the HPV DNA testing, which has got more sensitivity. We should arrange at least for 2 HPV DNA testing in a woman's lifetime. And we should also arrange proper collection centers. See, it is not enough if the woman, the doctor takes the tests. The lab should arrange collection centers so that they pick up the specimens and take it to the labs. And probably I should say that in the last couple of years, we have done an excellent job in giving the vaccination, training our people in the screening programs. And I think this gaining momentum has probably been because of the work of people like the Public Awareness Committee of Fogsi. So hats off to you all. It is really gaining momentum, and time has come that everyone will learn about it and ask more questions, and we will have more answers for them. Thank you.
Thank you, madam.
Thank you, Serena ma'am, for giving us such a good take-home messages. And I sincerely thank Bharati Rajshekhar madam for making such an excellent PPT with practical problems and solutions also. And I thank all the panelists and I thank the organizers, Priyankur and Alka Pandey madam also for the opportunity. Thank you.
Thank you, Aruna.
Thank you all.
Thank you, everybody. Thank you, everybody.
Thank you very much.
Thank you.
Thank you all.
Thank you, Sarina ma'am.
Dr. Monica, over to you. Thank you for the,
really,
the extra time, Priyankur. Thanks for the extra time.
Very beautiful.
Thank you.
Wonderful, Bharti. It was a very good show. Thank you.
Thanks,
Thank you
Rupa.
very much.
Thank you, Rupa.
Thank you, Bharti madam, and I apologize for my technical hitch.
No problem. It always happens. Don't worry.
Excellent slides, madam. Thank you.
Excellent. Excellent.
It was really very informative. It's very informative, and it makes even though you can put those slides in our clinics. And I think Bharti madam, you are supposed to give us one this
She
local
showed.
language slide.
I'm giving it to you.
She showed.
Okay.
Yeah, you didn't see
showed
that.
it.
Yeah, this is the last but one
She
slide.
showed. Madam showed.
I will send you the
missed
soft
it.
I will
copy.
take from her afterward.
I'll send you the soft copy. It's in Kannada, 2
Yeah.
pages.
Congratulations.
One
Congratulations,
is for breast and one is
Bharti.
for CS cervix screening and vaccination.
Yeah. Very nice.
Yes. Thank you, ma'am. Thank you, Bharti ma'am. That was indeed an excellent presentation. Thank you, Aruna ma'am. Thank you, Sarina ma'am.
Yeah.
And thank you, panelists. We'll move on to the next session now. The next panel is on modalities of conservative management of CS cervix. We have our moderators in Dr. Raghavendra sir and Dr. Kiranmai ma'am. And our expert panelist for the session is Dr. Manjula ma'am. Can we have the slide, please, Abhishek? Yeah, Dr. Kiranmai ma'am is, good evening, ma'am. Good evening, ma'am. She is the professor in OBGY at GMC Vanapati and at Kaloji University of Health Sciences, Telangana. She is the current chairperson of the Fogsi Say No to Violence Against Women Committee till 2025 and also a core member of the...
I think that would be enough. We are already running late.
Yes, ma'am. Welcome. Yeah. Next slide, please. Our next moderator is Dr. Raghavendra sir. He is, of course, our South Zone coordinator for the Public Awareness Committee and director of Infertility and Feto-Maternal Unit at Sunrise Hospital. Welcome, sir. Yeah, and our expert panelist is Dr. Manjula Anagani ma'am. Ma'am is MD FICOG and a Padma Shri awardee in 2015. She is the co-founder for Pratyusha Support and NGO and also a Guinness record holder for highest number of fibroids removed in a single patient. Welcome, Manjula ma'am. Really looking forward to your comments.
Thank you.
Can we have the please, Abhishek? Yeah. CV slides, please. We welcome our esteemed panelists. Our first panelist is Captain T. Seshasai. Sir has worked in Army as a captain for 5 years and he is also the NSS program officer at SV Medical College, Tirupati and has been practicing in Tirupati for over 20 years. We welcome you, sir. Next slide, please. Yeah. Our next panelist is Dr. Maya Malia, madam. She is the current president of KOGS and she's trained in laparoscopy, gynae surgery as well as colposcopy. We welcome you, Maya ma'am.
Thank you, ma'am.
Our next panelist is Dr. K. Sunita ma'am. Ma'am is the associate professor at SV Medical College, Tirupati, and she has over 6 publications to her credit, and she has undergone various trainings in hysterolaparoscopies. Welcome, Sunita ma'am. Our next panelist is Dr. Sandhya Rani ma'am. She is the director and chief consultant at Lakshmi Narasimha Hospital and Ekashila Hospital, Hanumanakonda. She is also a member of Fogsi and current member of WOGS. Welcome, Sandhya ma'am. Our next panelist is Dr. Aparna Anil Vatamwar ma'am. She's trained in FMAS at World Laparoscopy Center, Delhi, and worked as an assistant in Government Medical College, Mehboob Nagar from 2017 to 2020. At present, consultant and head at Anil Surgicare Hospital, Mehboob Nagar. Welcome, Aparna ma'am.
Thank you, ma'am.
Our next panelist, Dr. Swati Rathod ma'am, the professor in Department of Obs and Gynecology at Christian Medical College, Vellore. She has various affiliations and publications to her credit, and the special interest is in maternal and fetal medicine and high-risk pregnancy. Welcome, Swati ma'am. Our next panelist is Dr. Mariam Iftikhar ma'am. Ma'am is the associate professor in gynecological oncology in Department of Oncology and Laparoscopic Robotic Surgeon at Yenapoya Medical College and Hospital, Mangalore. Welcome, Mariam ma'am.
Yeah, thank you. Thank you.
Welcome. And we have next Dr. Ramya ma'am. She is currently assistant professor in Department of OBGY at Yenapoya Medical College, Mangalore. And her areas of specialization is minimally invasive surgery and urogynecology. Welcome, Ramya ma'am. Yes, a warm welcome to all the panelists. I now will request ma'am to kindly start with the panel discussion, please. Dr. Raghavendra sir, have you joined, sir? I guess sir is stuck with some emergency. Ma'am, I would request you to start, then sir will join us in the meanwhile.
And in case Dr. Raghavendra sir is not there, I think I'll entrust this responsibility to Dr. Monica because she'll join in emergency.
Yes, ma'am. Monica will join, ma'am.
Yeah.
Yes, ma'am.
So first of all,
okay, over to you.
Yeah. Am I audible?
Ma'am. Yes, ma'am. You're audible.
Yes, ma'am. So I think we are definitely late, but excellent session of the Public Awareness Committee. Hearty congratulations to the anchor, Dr. Bharti, Dr. Shatabdi, Dr. Monica. Wonderful efforts, and both the sessions were extremely good. And thank Fogsi, our President Rishikesh sir, our Vice President Alka Madam and all. And I see that our panelists are really hand-picked and chosen. All are experts in the field, and we have the additional benefit of having my dear friend, senior Dr. Manjula, Padma Shri Dr. Manjula, who has wonderful experience, and she's a real expert. Thanks, Dr. Manju.
Thank you, Kiran. Thank you for having me.
So my job is easy, I would say. Anyway, I'll start, and I think we have to not rush, but definitely we'll go for a crisp question answer session. Is it audible? Is it visible?
No, ma'am, not yet.
Yes, not yet, ma'am.
My net connection is some problem. It seems stuck.
Ma'am, it shows that you have started the screen sharing, but not visible yet.
Oh, yeah. Is it okay now? Oh,
not yet, ma'am.
Yeah, let me try again. I'll stop my video for a while.
Yeah, yes, ma'am.
Yeah. Is it visible now?
Yes, ma'am. It is visible. Just make it screen show,
yes.
Slideshow. Sorry. On the bottom side.
Yeah, there seems to be some lag on internet from my side.
Yes, ma'am. Clear, ma'am.
So let's move on. Move ahead of the facts and the burden of disease and the importance of screening, how it affects. And we all know the 70-90 goal, and it is definitely our responsibility. We can no longer run away from this. We also know that there are basically three primary screening methods. HPV DNA, as I find the final message is we are moving towards HPV DNA, moving away from pap smear. And in low resource setting, it is mostly the VILI, that is see and treat approach. So the first case I would go ahead is she's a young woman, 35 years, G2A1, still not having children, who has come to our OPD with white discharge, and apparently the examination, the per abdomen, per speckle and PV examination is normal, and the pap smear showed the Bethesda is what we have to follow, that is HSIL. So now what will you do? What next? Do you want to triage, or do you want to just treat her immediately or follow up? Can I have one of the panelists? Either Dr. Maya or Dr. Sunita or Dr. Sanjay, anyone can take this question.
Shall I take? I'm Dr. Maya.
Yes, Dr.
Actually, because of during pregnancy, because of increased vascularity and some hormonal changes.
She's not pregnant, ma'am. She's not pregnant. She's not.
But gravida too, it is written.
Sorry. No. This is let me correct this. She's not pregnant. She's desirous of pregnancy.
Okay. So if she is not pregnant, we can go for this one, a colposcopy, and we can see under colposcopy guided, we can go for a biopsy also.
Okay. So Dr. Maya would like to go for a colposcopy. That is, she want to triage and then go for a
Colposcopy guided biopsy under VIA or colposcopy guided biopsy will be better for this patient.
So WHO says that it is screen and treat approach or screen, triage and treat approach if it is a single visit or multiple visit depending upon the resource settings. So again, based on the WHO guidelines, because cytology is being used as a primary screening test here. So Dr. Maya says we'll have a colposcopy, then depending on the colposcopy triage, biopsy and then treatment. Any other investigations that you would like to have? We have
HPV we can do because nowadays because of increased sensitivity, it says that sensitivity is more in HPV test. So and specificity also. So we'll go for HPV test also.
Dr. Manjula.
Yep, I would definitely go for a HPV liquid. Co-testing is the need for the day, especially with HSIL. Because that will determine me, tell me what I should be doing for her. Because with pregnancy, we know it can actually go more faster, the progress of the disease. So I would go.
She's not pregnant. Sorry about that.
Yeah, I understand. But next she'll become pregnant. So I need to be very clear about it. So I would definitely go for co-testing and then discuss with her the options and then go for the treatment part of it.
Okay. Okay, then role of colposcopy.
Colposcopy guided biopsy is definitely advisable, and co-testing. That is the reason I said we would be going for co-testing both for HPV plus colposcopy guided biopsy.
Okay. So anybody else, Dr. Sunita, you would like to tell us about the colposcopy? Not basically the entire procedure, but very briefly about it. What are the advantages and do we have Dr. Sunita here?
I can take the question, ma'am. I'm
Yes,
Dr. Anjan here.
Yeah.
So basically, the indications of colposcopy will be like anything apart from pap smear normal and ascus, which is HPV negative after triaging. We'll definitely go. All the other things we'll go for colposcopy, like BLC, LETC, ASCH, AGC, NOC, and endocarcinoma, AIS. So everything except normal pap smear as well as ascus, which is HPV negative, will go for colposcopy. So it goes for the indications of colposcopy. Apart from that, the idea of doing it is to evaluate where is the lesion, which quadrant it is, to see the extent as well as the grade of the lesion, and we go for a colposcopic directed biopsy. We will go. Again, we can follow modified Reed's index as well as squeeze scoring. Depending upon that, further management is there, and we can follow any of the guidelines. We have ACP guidelines, which clearly gives the flow charts for all the practitioners. Sitting in the OPD, you just have to search in the Google, put in the ACP guidelines, and that gives you a beautiful flow chart of what has to be done where, even if it's pregnant, less than 25, more than 25.
Yep.
Yeah. Now, what is considered an adequate colposcopy?
Where that squamocolumnar junction is properly visible, and that is TZ1.
Okay.
That's the proper that area and we should see periphery also very clearly, if possible, vagina also.
Yeah. So this was an adequate colposcopy and endocervical curettage. Do you all go for endocervical curettage in this case? For example, this was an HSIL apparently normal cervix.
Absolutely.
Yes,
endocervical curettage is a must.
Is a must. So it is normal, and the biopsy had come to be CIN2. Now what next?
CIN2.
We can go for any of the thermoablation method or whatever is available.
So any Dr. Maya says thermoablation. This is the flowchart that I have taken from the Fogsi GCPR 2018.
Yeah, Dr. Kiran, can I add something here?
Yes. Leela, ma'am? Is it Dr. Leela?
Yeah.
Yes,
no,
ma'am.
you are saying that the biopsy is showing CIN2. Am I right?
Right.
Yeah. So actually now there is a change in the terminology of this CIN. No longer they are using CIN. They are using either LCL or HCL. But okay, even if you have used CIN2 is actually a gray area. So in this particular situations, when you get a biopsy report of CIN2, the one of the advantage, then like the latest advances in good centers is they do IHC, that is immunohistochemistry, for P16.
Yeah.
Okay. Ki67. If immunohistochemistry shows positivity, that is the block positivity, that means the entire abnormal area is picked up by IHC markers, then you have to consider it as a high grade. That means the chance of it becoming a higher grade or progression is more. If IHC is negative, then you can consider it is towards a lower grade. So that is one.
Leela ma'am, in case I don't have this facility of immunohistochemistry.
Yes. And if you don't have the facility, that is okay. Then you have to individualize according to the history and everything. But if you have a facility, you can do IHC. But you said the lady is only desirous of pregnancy.
Yeah. So the even follow-up is also an acceptable option. That's what I wanted to ask.
Yep.
One is a follow-up. The other is triaging, as you have said, with immunohistochemistry, if it is CIN2. And going ahead with an excisional procedure. All the three are acceptable. Is it so?
Yeah, I mean, in this particular lady, if you have CIN2 and the entire transformation zone is visible in this patient, and the one advantage of this IHC is if it is not a IHC positive, if it's a lower grade, then you can even think of an ablative treatment. That is an advantage.
That is an advantage.
If you want to consider treatment for this lady, if it is IHC positive, then probably you may think twice before going for ablation. But anyway, if somebody is keen for pregnancy and all, maybe you should not straight away jump and do excisional methods. And here the picture what you have shown has nicely showing a type 1 teaser. The entire lesion is visible on the ectocervix. So ablation is still possible. And of course, follow-up is another option in CIN2 also. There is a chance of regression. But she has to be on a very close follow-up.
Yeah. So,
Madam, but in ablation, you won't get the tissue for examination.
Already biopsy has been. You have already done the biopsy and you have said it is CIN2. If you have not done the biopsy, then you won't get any histopathological report in ablation.
Okay.
So can anybody tell in brief about cryotherapy, the procedure, its advantages, disadvantages? Dr. Sunita, you can go ahead.
Yes, cryotherapy is usually done with nitrous oxide. It is freezing of the tissues. Usually we use 3 minutes, 5 minutes and 3 minutes freeze thaw and freeze technique. But there are some disadvantages. It is done in outpatient procedure only without any anesthesia. That is the advantage of the procedure. And
what are the prerequisites?
Just we have to go with our pap smear should be done prior itself.
Yeah.
We should confirm the diagnosis. And it should be seen 1 or 2 lesions and not going beyond that transformation zone into the endocervical lesion cannot be there. All those things should be there before taking her for cryotherapy. The complication with it is excessive patient complaints of excessive vaginal discharge, watery discharge, which is causing inconvenience to the patient.
Any complications?
I think minimal complications are with cryotherapy. There are chances of no chances of bleeding in this patient. Watery discharge is the only complication we'll get.
Can I have Dr. Leela madam, and previously also there was so much talk about this thermal ablation. Can someone tell about the principle and its major advantages right now? Because in the see and treat approach in low resource settings, we are employing VILI or VIA, and then immediately when paramedical trained staff nurses are doing this at the same sitting, thermal ablation. Then we have Dr. Aparna or Dr. Swati, Dr. Ramya, who have not imparted till now. Do we have Dr. Swati here? Or any one of you, please.
Usually can I tell that usually that probe will be the temperature will be reduced to -50 degrees, and then either nitrous oxide or carbon dioxide is the gas is passed through the probe, and when it touches the
Ma'am, that is about cryotherapy,
That is
I
about
guess.
cryo,
Thermal ablation has got two companies like Visap and Zepmo.
Yes,
So they have got these 3 probes of different sizes, so you can cover that lesion. And where the temperature is increased, it has got a beep sound. So initially, when you put in the probe, it has got a button where you after you insert and you have the target lesion pressed on the cervix. It's again OPD procedures. It is OPD and it is painless. So once you're inside and you're touching the cervix with the probe, depending upon the size, you have 3 different probes. So once you're inside, you press the button and then it beeps or it has a light once it reaches the 100 degree. And then again, you have a beep, which it calms down, it cools down, and then you remove the probe out. And this is battery operated, so you can carry it at the camp settings. It is portable and it's a very small box, like, hardly like about like 30 centimeters small box. So you can immediately do the screen and treat in this thermal ablation. Only disadvantage is that you will not get unlike a cone biopsy and leaf, you will not get a biopsy, like a tissue specimen as such. So you have to make sure that we are dealing with the low-grade lesion, which is HPV negative or say P16 or P67 negative. It is advantageous over the cryotherapy.
I would like to ask either Leela Madam or Dr. Manjula here.
Yeah. The advantage, Kiran, here is that it is a very short setting, like 20 to 40-second cycles, and repeatedly you can use. That is the thing.
That is
Ma'am, whether in HPV positive we should not use it.
No, it's not like HPV positive you cannot use. It can be used as long as it is in the LSIL or HSIL.
Only thing is in see and treat wherein they are doing a VIA with acetic acid and they are ablating these lesions. So before doing thermal ablation, a biopsy is a must.
Yes.
Leela,
We
ma'am,
need to have a tissue biopsy.
In screen and treat approach, we sometimes don't do biopsy. So in screen and treat approach using VIA or HPV testing. So even if you do HPV testing, you have seen the lesion, you have to see the aceto whiteness. So suppose if it is a thin aceto white, the lesion is with a diffuse borders, there is no abnormality, there is no vascular abnormality and other things. So you can use a thermal ablation. It is in place of cryo. So cryo and thermal ablation can be done in positive men. You can definitely do it without a biopsy. If you have a suspicion that maybe she's harboring a high-grade lesion,
my doubt and
then
question
you have to do
no, is there a chance of missing malignancy if you are not taking biopsy? Even if it is a remote chance, in case we are not taking biopsy in low resource settings.
There can be over treatment, there can be under treatment. I don't deny that. There can be always over treatment. So it all depends on how experienced you are doing in VIA interpretation. So that is the one which matters. Of course, if you have the facility to do biopsy for every woman, you can do it.
Yes. So in the case of a low resource setting, or in case where we are not able to do a biopsy, that should not deter us from
screen and treat
approach. Yeah.
Yes.
Screening.
Can anyone, any of the panelists? Yes, ma'am. Yes, we got the message. So regarding LEAP, that is loop electrosurgical excision procedure, what is it and what are the advantages or disadvantages and what is the setting that setup that we have that we need? Anybody?
This
which we can use, of course.
Loop electrosurgical excision procedures usually utilizes this electric wire to remove the chunk of the suspected tissue from the cervix, and it needs the local anesthesia. At least we'll give a cervical block, and then we'll be taking in our hospital. We don't go for general anesthesia and other things, short general, but local anesthesia is enough to take that area of lesion from the cervix.
What additional advantages, Dr. Sunita, apart from getting the sample for HPE?
Additional, you can reduce the burden of the disease from the cervix also, no? You can remove that area of affected area.
The lesion extending to the endocervical region can also be removed with this leaf.
In that case, we have to go with the large loop excision of the transformation zone. You can also go with LEDs.
Dr. Manju, I want you to elaborate on this LEAP and LEDs. How different are they?
Yeah, LEAP is something where we have a small electrical loop through which we remove the complete the abnormal cells from the cervix. So this is something like Dr. Maya and everybody said that it is for biopsy and then through which we can go and then remove it. But one thing we need to understand is that if we are doing in an OP setting and we are not using anything else to be doing it, the chance of bleeding will be there even though whenever we are doing it. So we might have to go in for thing. But LEDs is a large loop excision of the transformation zone. That's where definitely the endocervical area and the transformation zone is definitely taken, a larger loop. Whereas LEAP, most of it is just the superficial cells and the abnormal cells which we see till we are not very sure that we would be going into the endocervical region.
So both
Very rarely we see, madam, bleeding.
Yeah.
Bleeding parvajanam, rarely we come across.
Yes. If we are going with LEAP, it is much lesser. But with LEDs, we do see, especially when the cases where you see a lot of raw area and abnormal tissues there and colposcopy showing a lot of vascular abnormalities there. That's where the bleeding is going to be more.
Okay. So how frequently have you seen these complications like cervical stenosis or issues with cervical incontinence?
Stenosis is something which we see more with LEDs than with LEAP. That is first thing. And the second thing is when it is when we talk about the incompetence, that happens only when we go very high cone or when we reach almost to the internal os. Otherwise, incompetence is usually not much seen with LEAP or LEDs.
So it is mostly the stenosis, and if you are really going deeper. Anybody?
Yeah, and as with cryocautery, even with LEAP and LEDs, there will be a lot of watery discharge for the first 2 weeks, which we have to counsel.
Okay. Anybody experienced with this cold knife conization, the number of cases you are experienced where you do use this cold knife conization as a conservative, Dr. Mariam, or if Dr. Swati is here, Dr. Seshasai, sir.
I have no experience with cold knife conization.
I do cold knife conization, ma'am.
Yeah.
It is with the scalp, and you remove the cone. It is the more useful when it comes to type 2 and type 3, where you have a inadequate colposcopy, or say when the transformation zone is receded inside. In that cases, and those who do not want hysterectomy, like SIN 2, SIN 3 lesions, in that cases we do a cold knife conization. Advantage here is that you do it along with the ECC as well. When we do this cone biopsy, we also do a ECC, endocervical curettage. And advantage is that we get a tissue, good tissue for biopsy, make sure that margins are negative. And again, it is also one of this one where you have a early CS cervix 1A. It also can be a CS cervix 1A who desires of fertility. This is also along with versus trachelectomy part. Micro invasive, so that is also one of the indication for cone biopsy. We do cases here. There are people who come here telling that we want to preserve uterus, even though they are 40, 45, telling that we want to preserve the SIN 2, SIN 3, we want to. In that cases, I go for cold knife. Of course, now
even if she is a 40-year-old lady with microinvasive cancer and is desirous of
desirous of fertility, then that's option. But radical trachelectomy is always preferred over this one, ma'am. Any other?
I would like to just add one more sentence to what Dr. Maya is saying. We do a lot of conizations because we still strongly believe that any infection is definitely not an indication for hysterectomy unless it is that. So whenever there is unsatisfactory colposcopic findings, or when there's positive endocervical curettage or biopsy, usually is when it comes, it's not invasive microinvasion or anything. That's when, again, like Dr. Maya said, when the lady wants to save the uterus, we go. Now, one thing what I wanted to add here is all these cases, we started doing a practice of suturing on both the descending cervicals and even anterior posterior. That prevents the bleeding. The amount of bleeding you see with cold knife is definitely quite high. We do know we need to have correct packing there. So once we started the practice of suturing on at both all the 4 quadrants, both at 12, 3, 4, and this thing, and tying it up, and then doing a cold knife, we do not have bleeding after the cold knife conization.
12, 6, 3, and 9, ma'am.
Yeah, you should just go 4 to 2, and we should again go from 10 to 11, that is 8 to 10, and again 11 to 1, and again we get the 5 to 7, and take a suture.
This makes it avascular and bleeding is
avascular, and it is by Vicryl, which is absorbable, and we do not have torrential bleeding, which is the most dreaded complication of this conization thing.
Do you fashion the, cervix again with cervical lips and all?
If we do a good conization, we don't have to do anything. With this suturing, and we do a good conization and go, we don't fashion anything. We just have to put a dilator so that there is the internal os is not going to be stenosed at the end of the procedure.
To get the feel of the os, we just put the dilator.
Yeah.
I would like to ask both Dr. Anjum and Dr. Manjula, how many cases of cold knife conization that you had done?
Oh, I must have done more than 50, Kiran, definitely.
Okay. Dr. Anjum?
I'm around almost around 30, ma'am. Now I have decreased because initially we didn't have a thermal ablation. Now once thermal ablation has come, and I prefer like thermal ablation much more.
Okay, so let's go
especially for the young.
Thank you all, really experts as panelists. So this is a 35-year-old again. Pap smear shows malignant cells. Colposcopy was done, and then they have done LEAP. And the biopsy is showing, it is a FIGO stage 1A CA cervix, but again, she wants to preserve her fertility. So what next? Can anyone just run through the FIGO 2018 staging in very brief, quickly? Dr. Sunita, Dr. Aparna, or I don't think we have Dr. Swati or Dr. Seshasai, sir. I thought he logged in. Any one of you, please.
Yeah, I can. Yeah.
Yes, ma'am. Quickly.
So now the staging is changed. I'm going to talk only very practical. I'm not going to get into details of it. So we have got, like, as a clinician, like as a surgeon, what do we know? That much only I'm going to tell it, ma'am.
Yep.
So we have got stage 1A, A1, A2. B has now, initially it was B1, B2. Now latest staging has become B1, B2, B3. And then comes 2A and 2B. Now beyond that is stage 3 onwards, 3A, 3B and 4. We all know that 4 is always distant meds. So I'm just going to keep out of it. Now in stage A1, A2, A1 is less than 3 and A2 is 3 to 5. But both are again microinvasive picked up in pap smear. Further, we'll subject them to colposcopy. Now, as clinicians, when we see in the gynae OPs, we see a lesion in the cervix. Now, how do we have to differentiate this? If it is less than 2 centimeter, it is B1. If it is more than 2 to 4, it is B2. Beyond 4, it is B3. So which are the ones we are sending immediately to a radiation oncologist? Any lesion which is beyond 4 centimeters, that is B3 onwards, or say there is a vaginal involvement, it becomes 2A. If there's a parametrial involvement, when you're doing a bio examination, if there's a parametrial involvement, it becomes 2B. If it's up to pelvic side wall, it becomes 3B. So anything beyond 1B3 onward, we'll send it to the radiation oncologist, and they will give a definitive RRT, radical RT, EBRT, as well as brachy. So we as clinicians are interested in any lesion up till B2.
Up till B2.
And up till B2. Now, one exception for this B3 is a young lady who is desirous, who is not very keen on radiation. There are centers which B3, they give chemotherapy 2 or 3 cycles of paclitacarbo, downsize the lesion, and take for radical hysterectomy. The idea behind avoiding this double modality is like radical surgery as well as radical radiation. To avoid that, we usually send them for adjuvant radiation, that they have a single radical modality. But there are some young ladies who prefer surgery or radiation. Such cases, we can give paclitacarbo and downsize in B3 lesion. That's all about it.
Yeah.
What stages are amenable for fertility sparing surgery?
This, I think I would like to take it. Early stage FIGO stage 1A through to 1B2, like Dr. Anjum just now said. Till that, when the woman wants to have a fertility sparing surgery or reproductive age group where pathological consistent definitely are with low risk, and some squamous adeno, I think negative lymph nodes. When we go and we can do a sentinel lymph nodes are negative, we stage 1A1 to stage 1B2. Till that, I think we can still make it amenable for this.
I want to clarify here. Is it 1B1 or even 1B2 also, Manju?
What? 1A1, 1A2, 1B1, and 1B2. Till that time, I think we can still go ahead with the fertility sparing surgeries.
Sir, I see you, Dr. Shesasai, sir. You would like to add here conservative fertility sparing surgery in case of early
Certainly, what she said is correct, madam.
Yeah.
It is adequate.
Okay. So, actually, we should be proud of these 2018 guidelines. One of our very own Dr. Neja Butler, Madam is, the main force behind this, and even in the 2021 update of the FIGO. So what FIGO says is in micro-invasive disease, that is 1A1, 1A2, that is generally made on a cone biopsy or a leap or a cold knife, which should include the entire lesion. And as you know, the depth of invasion should not be greater than 3 or 5 millimeters. So the treatment is, I would like our experts to comment. Suppose this is 1A1. As is. She's 35-year-old, 1A1.
I think 1A1, I think we can go ahead with conization.
With conization. Okay. Any lymph node sampling here?
See, with 1A1, the chance of lymph node is less than even 1%. I don't think we would be doing anything which is...
Can anyone, Dr. Anjum or, comment on this lymphovascular space invasion? I mean, that is one thing. If it is evident, the FIGO says pelvic lymphadenectomy should be considered.
Yes, we can go, ma'am, for that. And now we have this minimal invasive, this one also. We can go through that and then do this one. If LVSI is there, we can go ahead and do a retroperitoneal lymph node dissection as well, pelvic lymph node dissection.
That is, we have to do a sentinel lymph node first.
Sentinel lymph node, yeah, if available is there, because not all centers have got sentinel
practical
lymph node.
Purposes, 1A1 doesn't mostly need.
Mostly doesn't need, and now if sentinel facility is available in any center, because not all centers have got either in lap or robo which has got firefly, or it's a lap which has got sentinel, then I think we can go ahead with the sentinel lymph node. Otherwise, they will go for that. It's a good LVSI positive. But anything 1A2 and B1, if we are doing, I think I would prefer radical trachelectomy with, as Madam told, Manjula Madam told, plus or minus
something
sentinel.
Which I really don't remember, witnessing or assisting or doing. I would request one of you to just
we did do a lot. I did do quite a few trachelectomies in most of these international patients who come to us after subtotal hysterectomy, not just for CS cervix. They come with only cervix with lot of the vault issues and a lot of pain and everything, vault adenomyosis, cervical issues. That's when we go ahead and we do a minimally invasive trachelectomy is done. So it's the same thing when we do, but CA for a malignancy, I have not done for any CIN, the 1A2 or anything like that, because once we know that most of our patients, once there is a fear of cancer, they always opt for the radical surgeries or radiation. That is what they do. But otherwise, theoretically, it should be the same thing what we do with the radical thing. Only thing that in simple trachelectomy, we do not remove the parametrium. We just take it out like a cylinder type of a thing, which we take out the whole cervix. And with radical, there is a parameter, the parametrium which is involved. So it can be both abdominal or even vaginal. Most of the trachelectomies, we just do a laparoscopic guided vaginal surgeries.
Okay, laparoscopically guided vaginal surgery.
Yeah, because when we do a radical trachelectomy, we remove the whole of the cervix, and then we have to do a uterovaginal anastomosis.
Dr. Anjum, you would like to add?
Yes, ma'am. Same here as well. Same as the procedure is as what Madam has told. But then as such, people coming in with the cervical, they would prefer going in for radical hysterectomy than trachelectomy.
It is really
especially in this.
a rare scenario, I think, where
in India, because the fear of cancer is too much, Kiran, in India.
I thought I was, this option was, though I was reading, So I just thought how many really undergo or do this.
But let me tell you, a little glorified conization is simple trachelectomy. So most of the time when we err on extra treating, it ends up being a simple trachelectomy than the only conization. When we say high cone and when we go ahead, most of the cervix, it is as good as simple trachelectomy.
Yeah, absolutely.
Okay, when with conization or maybe radical trachelectomy, I really don't know how many or how far we can discuss, but what would be the pregnancy outcome? What will be the
post-surgery, Kiran?
Yeah.
So I think we should be anticipating few things post-surgery after we do anything. One is, like you said, stenosis leading to infertility or insufficiency leading to second trimester. This is something which we have to understand, as a cervical factor can be there. But chorioamnionitis, subsequent PPROM, preterm labor, these are also known to happen. But when we do a cerclage and then continue, most of the patients, we can go till at least viability age in today's times.
I would like to ask again, we have real experts who are dealing with this onco cases. You have had experience with pregnancy post treatment of early CS cervix. Following
I had only one case.
Dr. Anjum, Dr. Maya, Dr. Seshasai, sir.
What is it, ma'am? Can I have the
After
question?
this conservative, suppose conization for early any microinvasive or 1A, any pregnancy was there which you had followed, or I mean post
trachelectomy, definitely no, ma'am. But then I think Kona was, as Madam has told, I think anticipatory cerclage can be done, but as such.
Okay. So, but it needs, this is an option, the conserving, the conservative surgeries and all for early stage cervical cancer, for those who are desiring for future pregnancy.
Actually, anticipatory cerclage, again, it's not a mandatory thing, but I'm sure there must be like precious pregnancy, right? Delayed, that is why all this thing, and for that, it may need it. But actually, as such, it's not a Persian indication to do a cerclage as such.
So what I have gleaned from the experts is mostly it is the conization. Trachelectomy is not really that much practiced, at least in the Indian scenario, but that is the option definitely described and discussed in the guidelines. And it requires careful selection, counseling, and then follow-up. With this, I hand over to Dr. Monica for the third case. Dr. Monica? Is she here?
One second, ma'am. Monica, are you there? Ma'am, she was.
I wanted to just ask everybody there. If once you do a like we've been talking about CA cervix and then we are looking at pregnancy. Okay, pregnancy is done. So how many of you would be voting for hysterectomy after that? Because the fear is still there. Because she had a 1A2 or 1B1 or 1A, whatever it is. We have done a conization and then we finished her fertility. Then how many of you would be just following it up, or how many of you would be actually voting for once the childbearing is complete?
Definitely want to go for hysterectomy, madam, once the family is completed.
Yeah, I think we all should be looking at again repeating HPV, and if it's still high risk HPV
What does the guidelines say? Actually, guidelines say close follow-up, I think.
Follow up with HPV, and if it says that if they remain positive for HPV, definitely once childbearing is complete, we should be going for definitive hysterectomy.
Advantage with CA
Doctor will demand hysterectomy once the family is completed.
Yep, agreed. Demand hysterectomy.
One advantage is what I'm saying is we have a long period of amenable for follow-up and different methods of following up. So as long as patient is with us, I think that option also is there. But again, as Dr. Manjula says, maybe after completion of family. Dr. Monica is not there. Shall I go ahead?
Yeah, please go ahead.
So this is a pregnant.
She's also stuck somewhere, ma'am. Please carry on, ma'am.
Everybody's stuck. 20 weeks of gestation. Again, it is showing a high grade HSIL. Now she's 20. let's again skip through this theory part. What are the cytological changes during pregnancy, which which may kind of mimic?
There can be glandular hyperplasia.
Yeah.
In immature metaplasia confused with cellular atopia, we can see, and increased false positives you'll be able to see on examination.
Colposcopy also there is increased vascularization.
Yeah, during pregnancy and
of more severe lesion. But again, biopsy, it has got good sensitivity and specificity. But again, with complications, again, because she's pregnant. And regarding CECT, can we use in pregnancy? If
No.
No.
Why can't we? Let me tell you one thing. How many of you did CECT in pregnancy in Corona? We all did it. So I think just being careful and putting the lead shield and doing it is everything changes with time.
Absolutely.
We have learned so many things because of Corona. So we should not be shying away from doing it.
The dose is just 1 CGY and the dose allowed is much more. Actually, if needed, if necessary, it can be done. That is
it can be done.
Now, what is your plan in this case? She's a HSIL and 20 weeks. Precursor lesion, not
Biopsy is telling what? HSIL only.
HSIL.
Then I think close follow-up and then waiting for her to deliver. That would be ideal, unless it is now stage 1A or something. But if it's HSIL, just following.
We need not rush and, do early radical here. This is again from the Fogsi GCPR. So low grade, it's just follow-up with colposcopy at 6 weeks. High grade, repeat colposcopy at every trimester is what the general
every 3 months.
Rule out invasive disease and again follow up in the 6 weeks postpartum. Whereas in invasive cancer, it is again different. This is a precursor lesion. You are going to closely follow up every trimester, and generally they regress, is what they say. Coming to the invasive CA cervix, what would be your take?
I think the discussion with the patient is very, very important. At 20 weeks, if she wants a termination of pregnancy, I would go for it's still early pregnancy. So terminate the pregnancy and then treat for malignancy.
So it is like the cutoff is 20 weeks. If it is less than 20 weeks, the cancer takes the precedence.
Yes.
I mean, treatment of the malignancy is important, immediate and definitive treatment. Radical hysterectomy with fetus in situ with lymphadenectomy or radiotherapy and whatever it is. Whereas if it is more than 20 weeks,
we can wait
till viability stage.
Viability, or at least 32 weeks, 34 weeks, and giving steroids, and even classical section and then radical hysterectomy. So these are from the FIGO.
And actually, it is also advised that we can do a radical hysterectomy at the time of cesarean.
Yes.
I don't know how many of us have done because we have never done. So I have no idea.
It is given. I mean, it is the plan, as Dr. Manjula was telling. It has to be discussed with the patient. It is a multidisciplinary approach. So before 20 weeks, they are treated without delay, and then late trimester onwards, again after delaying definitive treatment is an option for stages 1A, 2 and 1B1 and 1B2. It is not shown to have any negative impact on the prognosis compared to non-pregnant patients. And timing of delivery, again, both maternal interest. Again, classical section and radical hysterectomy is from the FIGO 2021 update. It can be undertaken at the same time, not later than 34 weeks.
Yep.
And route of delivery, any contraindication for vaginal delivery?
I think if it's only conization or anything, we can allow vaginal delivery. There is no other obstacle.
Anyway, the route of delivery doesn't matter. Pregnancy, any regarding this? Conization in pregnancy, Manjula or
No. In pregnancy, we usually do not do anything of that sort. But theoretically, leads and leaps can be done.
But anyway, high grade, even HSIL also, we are going to follow up.
Yeah, just follow up.
With colposcopy.
More frequent. So if it is precursor lesion, then vaginal delivery is definitely not contraindicated. We should go for it. Micro-invasive, there is some suspicion of disease progression and all, but definitely we can have a vaginal delivery.
Again, route of delivery will not actually matter.
But anyway, advanced or later stages, maybe cesarean section.
You have to go for cesarean.
Cesarean, and just now we spoke about cesarean radical. So I think we should think of that if it's an advanced.
So there ends the panel. I think I'm lucky, really lucky to have all of you, especially thanks,
Thank
Manju.
you. Thank you, Kiran. It was a wonderful thing.
I just got all my answers from the experts.
No.
Really
You
excited.
Thank you.
Said I could not say no.
Thank you, Dr. Kiranmai, and thank you, Dr. Manjula ma'am.
Thank you, ma'am.
Happy to be with you.
Dr. Malia.
Thank you,
Thank
Manila
you,
ma'am.
ma'am. It was a very good academic
Thank you, Pat.
session.
Thank you, all
Yeah,
of you.
thank you. It was a
a
very good,
wonderful Anjum, you
good
were great.
academic session. Yeah, ma'am. Thank you, ma'am. It was a good
Thank you all,
academic session.
Thank you, Sesha Sai sir.
Thank you, madam.
Swati was there, but I don't know.
Thank you, Kiranmai ma'am. Thank you, Kiranmai ma'am, and heartfelt thanks to Manjula ma'am, Maya ma'am, Anjum ma'am, and Sesha Sai sir, of course.
Thank you,
Kiranmai ma'am, for taking out
Thank you.
and just conducting the whole panel by yourself. Heartfelt gratitude to you, ma'am.
Yeah.
Thank you. Thank you all. Thank you.
Thank you so much.
Satabdi ma'am, you are on mute.
Yeah, am I audible now?
Yes, ma'am.
Yeah. So my heartfelt, thereby we have come to the end of our discussion for our academic session for today. Heartiest thanks to everyone who was present today by taking out time from your busy schedules. You all have really made our effort worthwhile. Heartfelt thanks to all the chief guests, the expert panelists, all our moderators, and including Bharti ma'am and Kiranmai ma'am. Thank you and have a good evening, everyone. Hope to see you all soon again with the next topic.
Good night,
Thank you,
everyone.
Abhishek. Thank you, Abhishek.
Good night.
Good night, ma'am.
Good night.